Good morning, ma'am.
Good morning, Dr. Chandrakanta. I was just wondering, कहीं फंस ना जाए.
जी मैम. So good morning, everyone, and a very happy Janmashtami. So before we start, I request our HOD ma'am, Dr. Shaili Avasthi ma'am, to introduce you about this training course.
Thank you, Dr. Chandrakanta, and a very good morning to all 750 of you, and perhaps more will join today. A very happy Janmashtami. All best wishes for a happy Janmashtami. Today is our 13th session we are conducting for doctors. And we have so far trained almost 4,500 plus doctors. Now, the basis of this training, the genesis of this training starts with the anticipation that the third wave of COVID might come. And therefore, we all will be prepared to look after our children better, not only our children, even the adults who come with COVID. We have learned a lot from the first wave, more from the second wave. And now, as we sit and watch in anticipation, the question which comes to everyone's mind is, will the third wave come? When will the third wave come? They keep asking me. They keep talking amongst each other. We keep talking amongst each other. While we hope that the third wave will not be as aggressive as the second wave, but we have to see what is happening in the United States, what is happening in the United Kingdom, when the schools are reopening, when the festive seasons begin, when the children go back to school. Any deviation from the COVID protocol, any vaccine hesitancy will make us pay again, as we paid in the second wave. We paid very heavily in the second wave. So this time we are wiser. Our PICUs are set up. Our adult ICUs were already set up in the second wave. People were apprehensive how we will be able to look after children. So now with this training and with our reassurance that all of you had pediatrics as a subject in the undergraduate level, you all have done internship in pediatrics, I have full confidence that if the third wave really involves our children, we will be able to take excellent care of these children when the third wave comes, if it comes. So, with these few words, I request you to hear attentively all 4 days, participate in the pre-test, participate in the post-test. If there are queries, ask questions to your facilitators, and I'm sure you will learn a lot. So, a very happy learning to all of you. And I would also like to thank DG Health, DG Medical Education, Dr. Chandrakanta and her dedication, Dr. Suyog Sidhu, who is there in DG office. All of you, happy learning and happy Janmashtami. Over to Dr. Chandrakanta.
Thank you, ma'am. And thank you for sparing your time. So I welcome all the participants again. So this 4-day long training program, this has been organized by DGME, DGHS, Department of Pediatrics, KGMU, along with the other collaborating colleges. And other collaborating colleges are SGPGI Lucknow, RML Hospital Lucknow, IMS BHU Varanasi, SRMS Bareilly, Super Specialty Hospital Noida, and AIMS Bareilly. So faculty from all these medical colleges were involved in making modules for this training program. And I hope you will find this training course helpful to you. And in this 4-day training program, as ma'am said, there will be a pre-test, and in the end of the training at day 4, there will be a post-test. So giving pre-test and post-test and attending all the days is mandatory for all the participants to get your certificate. And in this 4-day long training program. We will discuss about the COVID-19, its presentation, management of mild, moderate, and severe cases, how to interpret chest X-ray, how to interpret ABG. So first day we will discuss the overview and mild, moderate cases. The second day we will focus on the oxygen therapy. We all know how important is the oxygen therapy and non-invasive ventilation in the management of COVID patient. Day 3 is mainly focused on the mechanical ventilation, how to do mechanical ventilation in children. And on day 4, again, we will discuss some important topics like shock, MIS, PICU management. So I hope you all will be wiser after attending this training course. So in the beginning, there is a pre-test. So pre-test link will be activated at 12:10. And before we activate pre-test link, Mr. Neeraj will brief you about the pre-test.
Thank you, ma'am. Good morning, everyone. This is basically the message what we have received on your WhatsApp. This is a sample in which we have shared total 4 links with you. All those who are waiting for the pre-test or calling on the number or messaging, I just want them to please listen to the instruction what I am giving because it is the instruction regarding the pre-test where you will find the link of the pre-test and how to give it. So this is the sample of the message what we have shared on you with you on the WhatsApp. It consists of 4 links. The first link is of basically agenda. Second link is of Zoom, using which you can connect on this meeting through Zoom app. Third is of YouTube. If you have any issue with the network or anything, you are not able to download Zoom, you can use the link to continue with the training. The last link is of post test. Is mentioned Google pre-test. Sorry, Google link for the pre-test day 1. You can use this link to submit your pre-test. If you have already clicked on this link before it's get activated, so I request you to please close that particular tab of the browser or complete browser. Any option you have used to open this page, because you have to click on this link when the link is activated, so that the general information, that is your name, email ID, mobile number, and also your participant ID will come pre-filled. So if you have already clicked on this page, I request you all to please close that particular tab and browser. And if you are unable to see these links in blue color on your WhatsApp, so you have to save the number from which you are receiving this WhatsApp messages, so that all the link will turn into blue color and you can use it. I'm also showing you a sample how it looks on WhatsApp. Basically, when this was a sample, when you can see only one link is visible, and you have to click on this read more button at the last. You can see the complete message. It consists of total 4 links, and the last link is of pre-test. No link will be shared now. It's already shared on the notification message today morning also, and yesterday also. You all have received the links. You have the links with you. You have to just locate the link on your message and you have to click on the link. Okay, your name, your mobile number, email ID, and also participant ID should come pre-filled. If it's not coming pre-filled, you have to close that particular tab and you have to click on that link again. So the test will be of 20 minutes. I'm activating the link. Just click on the link when I share that the link is activated. Just wait. Link is activated. You all can submit your pre-test. If you're facing any issue with the pre-test, you can also WhatsApp on the number from which you are receiving these links.
जिन्होंने प्रीटेस्ट लिंक को टाइम से पहले क्लिक किया है, उन्हें लिंक को फिर दोबारा से क्लिक करना पड़ेगा। अगर आपने टाइम से पहले प्रीटेस्ट लिंक को क्लिक किया है तो प्लीज उसको ब्राउजर को क्लोज कर दें और फिर दोबारा से ट्राई करें। अगर आपको प्रीटेस्ट देने में कोई परेशानी आ रही है तो जो व्हाट्सएप नंबर दिया गया है उस पर मैसेज करें। Pretest link is active now. So if you have clicked the link before time, you have to close the browser and click it again. And if you are still facing problem, then WhatsApp on the given number. Pretest link has been shared with you already, and if you go to your WhatsApp messages, then you will find your pretest link. Just to inform them, if you have those who have joined late, that pretest is going on. So you have to submit your pretest till 12:30, and session will start at 12:30. If you have joined late, please do your pretest first. Please note that pre-test link will be closed at 12:30. So submit your pre-test before 12:30. जिन्हें प्री-टेस्ट करने में परेशानी आ रही है वो दिए हुए व्हाट्सएप नंबर पे मैसेज करें। इस मीटिंग में उनको हेल्प करना संभव नहीं होगा चैट बॉक्स की से, तो जिनको भी प्रॉब्लम है वो दिए हुए व्हाट्सएप नंबर पे मैसेज करें। आई होप आप सब लोगों ने अपना प्री टेस्ट सबमिट कर दिया होगा, और जिन्होंने सबमिट नहीं किया है 2 मिनट, प्री टेस्ट लिंक अभी एक्टिवेटेड है, सो अपना प्री टेस्ट जो है वो जल्दी से सबमिट कर दें. So now we start our session, and today Dr. Arpita Brigvanshi from Department of Pediatrics KGMU will be moderating the pre-lunch session, and also she will be taking the first talk on overview of pediatric COVID-19 general management and the clinical presentation. So she is Associate Professor of Pediatrics at KGMU Lucknow. So I request Dr. Arpita to please start with the first talk.
Thank you so much, ma'am, for such kind introduction. I'll immediately begin by sharing my presentation.
If you have any query, please write on question answer box.
So I hope I'm audible, ma'am, and my slide is visible.
Yes, Dr. Arpita.
Okay, thank you so much, ma'am. Good afternoon, everyone, and welcome to this pediatric COVID-19 training in children. And the first lecture which I'll be taking will be COVID-19 infection in children. It will be a brief overview and not an elaborate management and clinical manifestation, because everything will be dealt with in detail in subsequent days. So it's just a brief overview of how COVID-19 affects children. So when we look at the trends of COVID-19, both globally as well as in India, we saw that the peak of COVID-19 in the world happened somewhere in November and December of 2020, and then the similar peak we observed in India, and the catastrophic peak happened in the April and the May of 2021, with the cases rising to about 22 million per day and deaths in 2 lakhs per day. So it was really a very catastrophic second wave which we saw in India. So why are we taking this training? Because there was so much of prediction that if at all a third wave comes, it is going to affect mostly children. So let's look at the figures of the first and the second wave. So when we look at the figures with the age in the x-axis and the percentage being in the y-axis, we see that in children or adolescents less than 20 years, the proportion or the percentage of children who were affected were less than 12%. When we talk about first as well as the second wave. However, because in the second wave, the absolute numbers were huge, enormous. So these absolute numbers of the children were also high when we compare it to the first wave. However, the percentage or the proportion of the children being affected in both the first and the second wave remained constant at around 12%. When we look at the mortality, so fortunately, children were less affected, and mortality was seen in only 3% of cases. You can see a similar, another diagram, a pyramid of blue and the red. So this shows the gender-based affection in the children. So male and female were equally affected, and there was no preponderance of either of the sex. So why did the second wave happen at all? Why was there a resurgence seen? So perhaps we were subjected to a considerable longer period of lockdown, and we lowered our guard seeing the low numbers of COVID-19. It was a complete state of unlock at the government as well as a general public level. There were mass gatherings happening, mass functions, and people were not actually following the COVID appropriate behaviors. If at all they were wearing masks, they were not wearing it uh, 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 according to the protocols. They were not following the social distancing norms, and perhaps there was also uh, appearance of mutant strains like Delta and Delta Plus in certain regions in India. So all together, everything clubbed together and led to the second wave. So uh, what we can do in COVID-19 infection? What is the solution? Because this is still we are learning this infection. It's been 2 years and still we are discovering newer manifestations, newer treatments. The things which were effective in the first wave were not in the recommendation the second wave. It's still a constant learning process. So what we can do is just to avoid this COVID-19 infection and take the preventive measures. So preventive measures, we all know that we have to follow these COVID appropriate behaviors. We have to follow hand washing, appropriate cough etiquettes, proper disposal of tissues we've used during coughing, take proper and immediate medical counseling if there is any problem in the if there is any symptoms developing. Prompt help should be sought of, and helpline numbers are there generated for the general public to take help 24/7. These helpline numbers are available, and we have to avoid mass gatherings, and we have to follow this the social distancing very, very adequately. We do not have to let off our guards at any times. So this was about the preventive measures. I'm not going to go into details of this. Only thing I'll stress in the slide is that nowadays a double mask protocol is advocated. So it is nothing but the proper use of a surgical mask, and to make it a proper fitting, you can use a cloth mask along with a surgical mask. Two surgical masks should not be used while following this double masking, or two cloth masks should not be used together, or for that matter, two N95 masks should not be used. It is the double masking is just for one surgical mask, and to make the fitting proper, because we don't get a proper seal with a surgical mask, you can make the fitting proper by using a cloth mask. This point I wanted to highlight. So are the children more prone in this surge? Let's look at the figures. We've already discussed that because in the first wave, less people were affected. In the second wave, more people were affected. In the first wave, only one person out of a family was affected and he was isolated. The other people were less affected. Here in the second wave, we observed the complete family being affected, and children were not less far behind. They were affected as part of the family. So absolute numbers, they increased when compared to the first wave. However, the percentage we talked about, it remained constant at about 10 to 12%. And along with that, because the vaccination process is underway in the adult population, so this COVID-19 has to find a host. So children being not vaccinated, it's a very good host for the COVID to enter. So that's why there's a prediction, and there are talks that the children might be more prone in this surge. Perhaps they will be, nobody knows, but we have to be prepared, and that's why this training is being conducted, that we are more familiar with the treatment protocols in the children as well. And there's another entity we'll be talking about, that is multi-system inflammatory syndrome. It is a very peculiar syndrome, which is most commonly seen in the children and adolescent groups and seldom seen in the adult population. But fortunately, the children we see the secondary infection rate, which is very low, and those children having severe infection and requiring hospitalization, as we go by the figures, it's very less. Coming to the effects of the COVID-19 in children, so this virus has certain direct effects and certain indirect effects. If we talk about the direct effect, the most common organ involved is the lungs. So the child may have symptoms of acute upper respiratory tract infections, such as mild running nose, mild grade fever, or he may present with pneumonia, the florid pneumonia-like symptoms such as fever with respiratory distress. There may also be uncommon symptoms where the GI system may be involved and certain systemic features, which we'll talk in later slides. And there's also an entity, MISC, in children. This also we're going to talk about, and atypical manifestations where certain skin manifestations or cardiac manifestations can also be seen in children, which is very seldom seen in the adults. Coming to the indirect effects, so because of this lockdown and closure of the schools and other healthcare facilities, the children were not able to access their routine healthcare services as well as their routine vaccination services. So this led to their being more sick because they were not getting a routine vaccination, as well as they were not able to get proper nutrition, because in most of the families belonging to the lower and middle socioeconomic strata, many of the parents, they lost their jobs, they didn't have any money in hand, they were not able to provide with proper nutrition to the entire family, children being included in them. So the general health of the children suffered during this period. As well as we talk about mental health in adults, it's very common phenomena even in children. So the mental health of these children also was affected because of the closure of the schools. They were more addicted to their gadgets, to the TV. They had more temper tantrums, and they couldn't meet their friends, so their mental health was also affected. So this was about the direct and the indirect effects of the COVID-19. Now let's move on to the modes of transmission. So as in the adults, the mode of transmission of this virus remains the same. It gets transmitted by the contact and the droplet transmission, which was more emphasized during the first wave, that we have to follow this social distancing, and we have to constantly hand wash whenever we touch common surfaces like switches of the common places, elevators, all those places. So contact transmission and the droplet transmission by large and smaller respiratory droplets that contain the virus, which would occur when you go very near to an affected person, was stressed upon in the first wave. However, in the second wave, we realized that this virus is also getting transmitted by airborne route by smaller droplets and particles, which remain suspended in the air over longer duration of time as well as distances. So if you see that you're in a public place and there are no people around you, and you presume that it's safe to remove your mask, it is not safe. That these droplets remain suspended in the air, in the atmosphere for longer period of time. So it is advisable that you remain masked all the time. So this airborne transmission was discovered and was emphasized in the second wave. So how to diagnose COVID-19 in children? The diagnosis remains the same as in the adults. So the RT-PCR being the gold standard for the diagnosis. However, if we do not have much time in hand, if we want quicker results, so we can make use of other faster methods like the CBNAT by expert or TrueNAT, which can give the results within like 4 to 6 hours. It's a chip-based test. Whereas RT-PCR requires the whole setup, whole lab to process a sample. There is also an ongoing talk about the newer molecular based test, which is nothing but the nucleic acid amplification test by CRISPR mediated detection test and the loop mediated isothermal amplification. However, it is still not being used in India because it still needs validation, but these are the newer methods which have been adopted elsewhere, but in India it still needs validation. Then in the ER, if the child comes to you in the emergency and you need a point of care testing, you can make use of antigen detection tests, just like the other HIV kit or the point of care test which we use for other infection. This is the same, and we get immediate result. It may take about 30 minutes. So this antigen detection detects the spike protein on this COVID-19 and gives quicker results. We can make use of this test in the emergency situations. Then we talk about antibody detection test. However, a word of caution should be exercised. It is not used for acute disease or active infection. This can only tell about a past exposure to the COVID-19, not an active disease. So what respiratory specimens we take while subjecting the child to these tests? The ideal would be a nasopharyngeal and an oropharyngeal swab. However, a trained healthcare personnel is required and he needs to be donned. So a lot of cost is involved while taking these samples. So certain countries like Japan, certain countries in Europe have started making use of saliva as a specimen for diagnosing COVID-19 in the community, if we say, because it's easier for self-testing of people and make better use of the resources available and at hand. However, in India, we still do not make use of saliva uh, uh, as a specimen for testing COVID-19. If the child is expectorating as in and is having like a productive cough, you can make use of sputum as a specimen for testing COVID-19. And if your child or if your patient is intubated, he is on ventilator, you can also make use of the lung fluids such as bronchoalveolar lavage fluid for testing whether he's still harboring COVID-19 or not. So to summarize, preferred test is RT-PCR and the CBNAT. CRISPR-mediated and the loop-mediated amplification test still needs validation in India. And antigen detection test by making use of nasopharyngeal swab, it can be used in the emergency situations. It is a rapid point of care test. However, a word of caution is exercised here because this antigen detection based testing does not make use of amplification process. So negative test does not rule out infection, and if the child still has symptoms, ongoing symptoms, you should always repeat an RT-PCR test in that case. A negative test does not rule out infection in that situation. Coming to the incubation period, the median incubation period ranges from 3 to 5 days as shown in this diagram. However, this is extrapolated from adult studies because the pediatric data is very limited, and a very peculiar thing was seen in the second wave where the incubation period was shortened to about 2 days also. So we take a range of 2 to 10 days to define incubation period in COVID-19. So the question which arises is that whether a COVID-19 infected child can transmit infection before the onset of symptoms. So very well, it is that the answer is yes, that because the transmission of COVID-19 starts 2 days before the onset of symptoms. During the incubation period, the child is still infectious and can transmit infection to other people. Coming to the types of clinical presentations, so it can be pre-symptomatic, which is the time period between the exposure to the virus and the development of the symptoms. The child may be infectious during the pre-symptomatic period, as discussed earlier. Then comes the asymptomatic child. In this, the test is positive. However, there are no clinical symptoms and the signs in the child. And if you're doing an X-ray in this type of situation, the X-ray is gonna come normal. How are these children identified then? They are identified through contact tracing, and they are also infectious. So they have to be isolated as adults. Then comes the classic manifestations. So the classic manifestations, we all know, the child may have fever, cough and cold. There might be sore throat in the child, and the child may or may not have lung involvement. So shortness of breath may or may not be present in the child. At this point of time, we do not have any clinical tool to distinguish it from other respiratory viral illness like adeno or respiratory syncytial virus. The symptoms will be similar to a common cold due to other viruses. Then comes the atypical presentations, which are very commonly seen in the children, where gastrointestinal symptoms are more common in about 5 to 10% of children. The child may be having diarrhea, mild abdominal pain, vomiting. These are the most common symptoms. Then comes the cutaneous manifestation seen in about less than 3% of children, where you can see these are the figures where you can see the maculopapular and urticarial or vesicle type eruptions, and the snake type serpentine transient livido reticularis in the skin of the children. There is also an entity which is known as the COVID toes, as seen in the figure. I'm unable to make use of the pointer, but yeah, this is the COVID toes, which are very frequently seen as a cutaneous manifestation in the child. The toes become red. There is purplish nodules on the distal digits in the children more frequently. Then comes the MIS-C. We'll be talking about that in the later half of my presentation. Coming to what drugs we have at hand while treating these children. So apart from systemic corticosteroids, which has a very strong recommendation while treating severe and critical COVID-19 infection, we do not really have much of the drugs in hand while treating these children. And there's a conditional recommendation against the use of remdesivir, so it totally relies on the physician's perspective whether to use or not to use these drugs. However, there is no role of hydroxychloroquine, ivermectin, and other antiviral drugs like lopinavir and ritonavir while treating this COVID-19 in children. There's no question of tocilizumab or other drugs being used in children. So what we have in hand is systemic corticosteroids, and we know this is a double-edged sword. So we have to exercise caution while prescribing this drug, and it should be prescribed only to those children who are very seriously ill and critically ill and hospitalized in an ICU. So how do you classify these children presenting to you with symptoms and signs of COVID-19? Based on the symptoms and signs, we classify it into mild, moderate, and severe illness. And depending on this classification, we then manage these children. In mild illness, the child will be having symptoms of common cold, like sore throat, slight watery running nose, slight cough, mild malaise, and fever. However, there will not be any signs and symptoms of lung involvement or parenchymal involvement. There will be no fast breathing seen in the child. Then comes the moderate illness. So here, there will be florid symptoms of pneumonia. How do you define pneumonia in child? So there should be presence of fever plus fast breathing to call it as pneumonia. And here I would stress upon the fact, because we have a mixed audience of pediatricians plus non-pediatricians, we have to make sure that we count the respiratory rate for complete 1 minute, because we know that the children are having periodic breathing. So not to miss out on fast breathing in children, we need to count for complete 1 minute. Then we have age-based cutoff to say that it is a fast breathing. So we have to remember less than 2 months if it is more than or equal to 60 per minute, 2 to 12 months if it is more than or equal to 50 per minute, 1 to 5 years if more than or equal to 40, and then more than 5 years if it is more than or equal to 30. So you can remember 60, 50, 40, 30, less than 2, 2 to 12, 1 to 5 years, and more than 5 years. Don't need to mug up or learn that. You can stick these age-based cutoff in your emergencies or in your wards. Along with this fast breathing, there should not be any signs suggesting of severe pneumonia or severe illness. There should be only fast breathing plus fever. Coming to the severe illness, the child along with pneumonia may have features of ARDS. The child may present to you with septic shock, sepsis-like features, or multi-organ dysfunction syndrome. So pneumonia with any of the symptoms such as cyanosis, saturations less than 90%, increase in the respiratory effort, such as you will observe severe retractions anywhere like intercostal, suprasternal, subcostal retractions, or there may be abnormal sounds such as grunting in the child observed, or abnormal breath sounds heard while you auscultate the child. And along with that, the child may have CNS symptoms like lethargy, somnolence, or seizures may also be present in this situation. So in mild illness, the child is normal. He'll have normal common cold like symptoms. Moderate illness, the child will have fast breathing plus fever. In severe, he will have multi-organ involvement, and saturations will be less than 90%. Moderate, the saturations will be 90 to 94, and in mild illness it will be more than 94% at all times. So we have to, whatever we classify the child when you see him, because this classification may change, it's a dynamic process, it might change. Monitoring is the key here, and you have to see that the moderate illness child does not slip into severe illness. Then he will be needing hospitalization in that situation. So mild disease I've already defined, and the saturation will be more than 94%. The respiratory rate will be well below the age specific cutoff. The child may have atypical manifestations such as GI and cutaneous manifestation. And if you're examining the throat of the child in that situation, taking all precautions, there you can see some congestion of the pharynx, and on auscultation, there will be no abnormal sounds heard. There will be normal vesicular sounds heard in that situation. I would also like to stress upon the fact that when you measure the respiratory rate, it has to be like taken. One respiratory rate is equal to inspiration and expiration as one respiratory rate. So I just wanted to stress upon this fact. So when a child comes to you with mild COVID-19 like symptoms, you can ask them for home isolation of this child. When the respiratory rate is less than the age specific cutoff and the saturation is more than 94%, you have to look for the other comorbidities in the child as in adults. So you have to take history of any cardiovascular disease or any congenital heart disease in the child. If at all the child is having diabetes, or he is a cancer patient or is on any anti-cancer drugs, he's having chronic lung, kidney or liver disease, or is having any cerebrovascular disease, or is a obese child. So obesity is a very important risk factor, be it a child or an adult, and it should be looked that these risk factors are not present when you're sending a child for home isolation. Along with that, you should also make sure that there are requisite facility for isolating him at his residence. He does not live in a closed one room setup. The caregiver is available to take care of him 24/7. He is not himself sick, not to be able to take care of him. In that situation, child line centers can come into picture, and they can take care of the child. And you should also make sure that the parents have agreed to monitor the health of the child, and they regularly inform his status to the surveillance officer or the doctor, calling them on regular basis over the phone. And along with that, you should have it signed by the parents or the caregiver. An undertaking should be taken that they should be following strict home isolation and the quarantine guidelines, because there is no point if they are not isolating themselves. So when can a child with mild disease need admission? So we've already discussed. So if the facilities of home isolation is not feasible in that condition of small house, or there's overcrowding at home, or the child is living with his grandparents or any other person who is at high risk, uh, and wherever the regular monitoring is not possible due to any reasons, this child needs admission for monitoring purpose. So it can be in the hospital or in a COVID care facility. If the child himself has high risk factors, he needs admission. And all children, whether they stay in a COVID care facility or in a hospital, they should be, they're not like adults, they are not small adults. They really need a very child friendly environment, and parents or his attendants should be allowed to take care with proper PPE kits and proper precautions. So this needs to be taken care of. So let's talk about the duration of isolation. We know in the adults it is of 10 days after becoming symptom free, but as in children, because they continue shedding their virus in the stools up to about 28 days. So this duration is a bit longer in the children, and it is 2 weeks after COVID-19 negative report coming negative. Moderate disease, I'm not going to repeat it. There will be pneumonia in the child, so fever plus fast breathing, and the saturation is between 90 to 94. Here the child will not be having any other organ involvement and will not be having any retractions or any audible breath sounds. Coming to severe illness, we've discussed this. So severe pneumonia with saturation less than 90%, with features with the severe retractions in the child and with other organ involvement is defined as severe illness. Coming to the treatment, so any child with severe illness really needs an admission in an ICU or a high dependency unit, especially those children who are having acute respiratory distress syndrome, that is severe pneumonia, sepsis, septic shock, or multi-organ dysfunction syndrome. And whenever you are admitting, you have to investigate the child. As an adult, you have to evaluate for thrombosis, hemophagocytosis, lymphohistiocytosis in the children, organ failure, and if it is present, you have to send appropriate investigations according to the organ involvement. Then the treatment in hand is only steroids plus minus remdesivir. So you have to take a caution here that you have to give remdesivir or not. Any child admitted in our ICUs, we usually start with the empirical antimicrobials just to take care of the hospital-acquired infections, and then you have to uh, uh, give oxygen therapy according to his saturation. You have to titrate whether he requires nasal prongs, face mask, high frequency nasal cannula, or non-invasive ventilation like BiPAP. Or if he's failing on either of these, you can then go on to invasive modes of ventilation. Then you have to really take care of the fluid therapy. In any child, we know that we have to calculate the fluid according to the weight of the child, and more so in a child with COVID-19, because they are at risk of ARDS. We have to follow a restrictive fluid therapy, and we have to give negative balance. As in adults also, because they are having risk of ARDS and volume overload, we have to always keep the child in negative fluid balance rather than positive fluid balance. And as the organs are getting affected, other organs are affected. If at all there is oliguria or anuria in the child, or other CNS or other organs are involved, you have to take care of that particular symptom too. So if the kidneys are failing, you can subject the child to peritoneal or hemodialysis, and so on. So severe illness in detail, in like brief, because uh, the management of shock and other ventilatory settings is another topic. I'll just giving you an overview of what we do while treating these critically ill child. When a child is having ARDS, the X-ray shows white out appearance. Then usually they require higher modes of ventilations like non BiPAP and HFNC. If he's failing on that, then we go on to intubate the child and keep him on ventilator. The setting should be protective. So a low tidal volume, like about 6 ml per kg, can be given to the child with high PEEP, which is a usual thing in ARDS. Make use of cuffed endotracheal tubes so that there is no air leak happening. Fluid restrictions I've already talked about, and these child need to be sedated or paralyzed so that an effective ventilation happens. There is no asynchrony between the patient and the ventilator. So make use of sedation and analgesia to keep them knocked out, and proper rest to the lungs so that they recover. And if there is poor response to that also, you can go on for your ECMO. If a child presents to you with shock, you have to take care whether it is a hypotensive shock, septic shock, or a myocardial or a cardiac origin shock. In case of a hypotensive shock, you can go for boluses with crystalloids like NS or RL at the rate of 10 to 12 milliliter per kg over 30 to 60 minutes. Fast, you can go faster if the child is hypotensive. However, you should take all precautions to look for subtle signs of myocardial dysfunction. If at all myocardium is involved, this fast boluses are avoided, because in that case the condition of the child will deteriorate. So you have to differentiate between a septic or a cardiac origin shock. Then if the child is not responding to your boluses, you can go for early inotropic support with dopamine or adrenaline. And you have to constantly monitor for fluid overload so that the child does not land up into fluid overload and ARDS. So now this is my final slide and a word about multi-system inflammatory disorder in children, a very peculiar and entity which is more commonly seen in children and adolescents. So this is about the diagnostic criteria. Fever of more than 3 days is an essential thing before you think about MISC. So you cannot think about MISC if the child comes to you with fever, cough, and cold of 1 day. You have to have a fever of more than 3 days along with 4 things. So as you can see, two of the following 5 things, that is rash or bilateral non-purulent conjunctivitis or mucocutaneous inflammation in the oral mucosa, hands or the feet, hypotension or shock, or features of myocardial dysfunction as suggested by echo findings or elevated TROP-T and proBNP, or there can be evidence of pericarditis, valvulitis, or coronary artery abnormalities seen on a echo. Absence of coagulopathy by doing prothrombin time, partial thromboplastin time, and D-dimers, or presence of acute gastrointestinal problems such as diarrhea, vomiting, or abdominal pain. So any two of these 5 symptoms when they are present, along with elevated markers of inflammation, such as we know we are routinely doing that in adults also. So elevated ESR, CRP, and procalcitonin, along with no other obvious microbial cause of inflammation, including bacterial sepsis, staphylococcal or streptococcal shock syndrome. This has to be ruled out that the symptoms are not due to bacterial sepsis, along with evidence of COVID-19, such as a positive RT-PCR antigen test or a serology positive. Here comes the role of antibody positive. So there should be a temporal association with COVID-19 as suggested by RT-PCR antigen or antibody test. So 4 things have to be there to make the diagnosis of MISC. Fever plus multi-organ involvement plus fever plus multi-organ involvement plus elevated inflammatory markers, absence of bacterial sepsis, along with temporal association of COVID-19. That's how we diagnose COVID-19. With that, I come to the end of my presentation, and I would like to sincerely thank all the contributors who made these beautiful presentations from KGMU, PGI, RML, IMSBHU, AIMS Raebareli, and Super Speciality Hospital Noida, and SRMS Bareilly. With that, I come to the end, and I would be very happy to take any questions if there are. You can type in the chat box or in the question answers. Can children be acquired infection through the GI route? No, the respiratory route is the mode of transmission in children as well as in the adults. Any other question? So dosage of remdesivir is also according to the weight of the child. That will be discussed in later on presentations. It will be dealt with in details. However, it should be very cautiously used. Yeah, the dose of the steroids will also be discussed. So I'm not going into the details of that here. What are your cutoffs for shock in children in COVID? So shock cutoffs, like if you're talking about blood pressures, so like hypotension is a late feature of shock in children, and you should rely more on the early clinical signs and symptoms like tachycardia, tachypnea in the child, decreased urine output. So these are the early symptoms and signs of shock, and hypotension, as I say, is a late feature of shock. However, it will be dealt in shock is a separate topic, so it will be dealt in the coming sessions. Till how many days after COVID MIS is said to have occurred? So MIS, there can be history of 1 month or 2 months, or sometimes in our emergency we do not get like history of positive contact also, but if there are symptoms and signs, we usually investigate these children and they have come to be positive. What antibiotics are preferred in children? So the antibiotic selection depends on the antibiogram of your own individual ICUs actually. So what bugs are there in your ICUs, you have to cover that bug. However, a broad spectrum antibiotics third generation cephalosporins and beta lactams are usually preferred. Inotropes and everything, shock management, I'm not going into the details of that because that's another topic. Is it advisable to send children to school these days? Actually, that depends on your own thinking. So I mean, if they take all COVID, if your children are mature enough to take all the COVID appropriate behavior, then you may as well send the children to the school. Is it safe to send children aged 6 years to school? That really depends on the maturity level of the child. And if your child is not confined to the to the house, he's going to the park and everywhere, he's going to the malls, then I may as well as say that like in school they will exercise precautions and take social COVID appropriate behavior. So it really depends on parents to take that decision, I would say. Is there any rational way to differentiate COVID than other respiratory illness? There is no rational way because the symptoms and signs, they overlap with like any respiratory virus. So moving further, I think I will type the other queries which are there in the chat box and go on to the next presentation. I would like to welcome Dr. Deepti Agarwal, faculty in RML Institute of Medical Sciences, Lucknow. She'll be talking on recognizing a sick child, normal vitals, and triage. I welcome you, ma'am, and over to you.
Thank you, Dr. Arpita. Okay, so I would like to thank all the organizing team, Dr. Prajapati, Dr. Shali ma'am, Dr. Chandrakanta, for the efforts that have been taken for these training modules and have been conducted maybe more than over months. These trainings have been conducted for the pediatricians and now more for the non-pediatrics doctors for dealing with this pandemic. Because as we understand this pandemic situation, if really the third wave happens to be predominantly of children, or maybe even if small percentage, then pediatricians will not be sufficient at most of the places to deal with. And we need our non-pediatrician colleagues to help in dealing with this pandemic situation. And that was possibly the rationale behind these trainings. So starting with the topic, I'll be talking very briefly on recognizing a sick child in normal vitals and the triage. The slide next, okay. Yes, the learning goals. Now, see, we know that children and adults are not same. The vital signs that we see in children are much different from that in adults. So it is very important for our non-pediatrician colleagues to understand that how they are different, so that we can understand that when to intervene, what is dangerous, and what is abnormal in a child, which may be not so in case of an adult. So we will be dealing with these vital signs. Then we will be talking about the pulse oximetry, which has been actually a very handy
Dr.
tool.
Deep,
I'm sorry to interrupt.
please
Can
share
you-
your screen.
Okay,
The
okay,
slides are not visible.
not visible. Okay,
Yes.
right again. I'll, is it visible now?
Yeah, yeah. Yes, it's visible now.
Okay. Okay. Audible too? Am I
Yes.
audible?
Yes.
Oh, okay. So what I was talking was that we need to recognize the vital signs in a child, and like what are the normal vitals? When do we call them abnormal? How do we recognize a sick
Please make
child?
it full screen.
Okay.
Ma'am, you can just do full screen on the right hand side. There is.
Screen's not happening.
Okay, it's a PDF version, I suppose.
PDF version, yes.
Ma'am, you can just zoom maximum so that.
Okay, that.
Yeah.
The last.
Okay, maybe
fifth
I'll try
Fifth
doing
option,
that.
ma'am, presentation.
I'll
Okay,
Last
try.
fifth.
there's a presentation option, ma'am.
Last
Present.
fifth.
Just a minute. Present.
On the upper band only, there's a selection option, presentation. No, ma'am.
Okay, like I've zoomed a little bit.
No, ma'am, you can click on the presentation. There's a presentation option. On the
Okay.
same, yeah.
Okay, yes, I
Try
got it.
click. Yeah,
Yes. So now it's full screen, I think.
yes. Okay. Thank you.
Now this Neeraj Mishra is requesting remote screen. Should I decline that?
Yes, ma'am. Now you have done full screen by yourself. Please decline.
Okay. Okay, so okay, starting again. So we were talking about recognizing a sick child, and why do we need to know what the normal vitals are in a child? Because we know the children and adults are not similar. And since these presentations are more for our non-pediatric colleagues, so we need to understand that how they are different and how when we call them sick. So now the learning objectives, we will be understanding the vital signs, that is basically the heart rate, the respiratory rate, the temperature, and the blood pressure. And now the pulse oximetry is considered as a fifth vital sign. And it has become actually a very handy tool and is also used at, I think it is now presently used in all the homes. Everybody's having that finger pulse oximeter to see the saturation. So it has really become a very handy tool. And also it is a good tool in the triage area to understand what is the saturation, as this parameter will be important in categorizing the children as mild, moderate, and severe. The third thing, how do we recognize that whether a child is sick? Like we had already went through in the previous presentation, that the categorization into mild, moderate, and severe had been done. Now, on what basis these were done? What were the vital signs? What was the saturation which led to these differentiation? That also we will be talking very briefly. We'll be seeing the red flag signs, particularly in relation to the COVID infection, and how do we triage the patients and why do we need to triage the pediatric patients. Now, coming to the assessment of the vital signs, we know that it is critical in all pediatric patients, and it includes the following. It includes the temperature, the heart rate, the respiratory rate, and the blood pressure. These are the 4 parameters which are very basic and help us to categorize our patients into various categories and to understand whether the child who is coming to the triage or the emergency area requires admission or not, is mildly sick, is moderately having moderate COVID symptoms, or is severely sick. So these parameters we'll go through how they are going to help us. Now, temperatures. Now we know that for the COVID-19 infection, this temperature is the most common symptom, and usually it is of high degree. And for children, we have to understand that how do we take the temperatures. Now, in adults, we all know that we usually take the oral temperature. But for young children, for infants, taking oral temperature will be difficult, will not be possible. So we have to take the axillary temperature. How do we take the axillary temperature? The thermometer has to be placed in the axillary pit, and it has to be placed vertically, and it has to be it has to be pressed against the chest, and it has to go vertically in the axilla, and it has to be kept, the digital thermometer has to be kept till the beep makes the sound and the temperature is then displayed digitally. Usually the cutoff for the fever is taken as 100.4 degree Fahrenheit. Anything below this is normal range of temperature, and anything 100.4 and above is taken as fever. But in axillary, usually the temperatures are 1 degree lower. So we can say that nearly 99.2 degree Fahrenheit is taken as the cutoff for fever in case of children when we measure with the axillary thermometer. Then this temperatures can also be taken by the rectal route. For the rectal route, there are different kinds of thermometers which are different from the regular digital thermometers that are available in the markets. So taking rectal temperatures, although they denote the core temperature, but they are not very much recommended. So for all practical purposes, we can take oral temperature or we take the axillary temperature, taking care that the axilla is dry and the thermometer is placed properly, that is vertically, in the axillary pit and is not lying loose. So these things have to be taken care of. Another thing to be noted, that there is a diurnal variation in the temperature. That is, the highest temperatures are usually reached in the evening and lower in the morning. So there may be, this is the normal circadian rhythm, and the temperatures may be little higher at the evening. Any abnormal rise in the body temperature. Now this symptom is important because it may be an indicator of the underlying condition, and in this scenario of the pandemic, if there is fever, then one has to consider COVID-19 infection as one of the important differentiators for it. Hyperpyrexia is taken when the temperatures are more than 104 degree Fahrenheit. So this is the first vital, that is taking temperature of the patient. Now coming to the heart rate. Now we see that this heart rate is age dependent. If we take different age groups, and even it is different in awake and sleeping heart rate. So when the child is lying stable, is quiet, then the heart rate that we get is the sleeping heart rate. For a neonate, that is less than 28 days of age, and for an infant, it is 160. If the heart rate is less than 160, it is normal. Anything going beyond that, beyond 160, is a abnormal heart rate. For toddlers, that is the age of 1 to 3 years, anything going beyond 120 is abnormal. For the preschoolers, that is 4 to 5 years, anything more than 100 will denote abnormal temperature. And for the school age children, that is 6 to 12 years, it is usually 90. And the same is for the adolescents, that is 90 is usually taken as the cutoff. So we see that as the age is proceeding, there is decline in the heart rate, which in the neonates may be as high as 160, which will be very, and in case of adolescent, it comes to around 90. Now, there can be various reasons of tachycardia. One of the very common reasons is having fever. And it is said that for that every 10 degree, if there is a rise in the heart rate, 1 degree rise in the temperature. It collaborates with 1 degree. Suppose if the temperature rises from 100.4 degree Fahrenheit to 101.4 degree Fahrenheit, then there will be an increase in heart rate by 10. So you can actually collaborate heart rate with fever to some extent. And also there may be other reasons of increase in heart rate, as there were some queries regarding shock. So yes, if a patient goes in shock, which is a severe sign of COVID infection, then also the heart rate will be much higher than the normal. So that is one thing, but it will be accompanied by other features like the peripheries will be cold, the respiration may be higher, and in late stages, the blood pressure will be lower. So in case of COVID, it is the fever that may lead to increase in heart rate. Secondly, it may be like we learned that often children present with GI symptoms. So if the children are having diarrhea, then they may have dehydration. Again, dehydration can present with increase in heart rate. So heart rate, if it is more than the cutoff for the age, then we have to be careful. We have to see whether it is due to high temperature. We have to see whether the child is dehydrated or not. And we have to see whether the child is sick or in a condition of shock. So these few conditions should be kept in mind when we are dealing with a COVID infected child. Yes, next, like this respiratory rate had already been talked in the previous session. Again, the respiratory rate, one, we have to be careful for the what are the cutoffs for the respiratory rate, because unless we know what are the cutoffs, we cannot understand that this is an abnormal situation and requires some kind of intervention. Like if a child is having fast breathing, again, it may be due to fever. Like if it's having high temperature, it could be fast breathing. Then it could be respiratory conditions, which is very common in case of COVID infection. Usually COVID will present as pneumonia. So if there is tachypnea, then you have to, and that is the respiratory condition could be the cause, or it could be some cardiac diseases also like myocarditis that may be the cause, or sometimes metabolic acidosis if child is having dehydration, or again in shock like stage and having metabolic acidosis, then also the respiratory rate will be increased. Now these cutoffs, I think these have to be given by the WHO and are very simple. Like if it is 60, more than 60, then it is 2 months. From 2 months to 12 months, the cutoff is 50. Then 12 months to 5 years, the cutoff is 40. And then beyond is 30. And we know that adults usually have a respiratory rate of 12 to 16 breaths per minute or cycles per minute. So knowing this, so you know that a child will breathe, even normally will breathe faster than an adult. But when one has to be careful, we have to be careful when we are getting a level more than 60 in a child less than 2 months, 50 in a child less than 12 months, 40 in a child less than 5 years, and 30 more than that. So these figures have to be known and are very useful when you are categorizing a child having maybe pneumonia or no pneumonia. So for understanding of the mild and moderate infection, this parameter becomes very important. Another thing which had been told in the previous slides by Dr. Arpita, that it has to be counted for 1 minute, especially in young children. Like you cannot count for 15 seconds and multiply by 4 as we usually do for adult, or 30 seconds. That cannot be done for children, especially these children less than 2 months and infants, because children have periodic breathing, that they may be sometimes breathing slowly and sometimes fast. So you cannot take the same thing. Okay, so that one has to be careful about it. Right. Next, we talk about blood pressure. Now, blood pressure is a marker of cardiac output, an indirect surrogate marker for the cardiac output. And if we have the normal charts, then you can define the hypotension less than 5th centile. In the subsequent slide, a very simple thing has been shown, that how you understand what is hypotension. And now understanding that there may be other causes also, like one is shock, may be a cause of hypertension. But in shock, if there is low blood pressure, then it is a very ominous sign, because it is indicating decompensated shock. Compensated shock will have a normal blood pressure and poor perfusion. Poor perfusion means that the peripheries will be cold. In a young child, you can see it by capillary refill time will be prolonged more than 3 seconds, and the peripheries will be cold and the heart rate will be more. So if these conditions, the poor perfusion condition is present with a normal BP, it indicates compensated shock. And if the BP is low, then it is uncompensated, decompensated shock. So if there is a fall in the systolic BP of more than 10 millimeter, it has to be worrisome, because whenever you are taking vitals, you are repeating it, you are monitoring the patient. And depending upon the sickness of the patient, like if the patient is more sick, maybe a half an hour, or if less, maybe 3 hourly monitoring is required, and or 6 hourly monitoring. So if you find a fall in blood pressure, it definitely is worrisome if the fall in the systolic blood pressure is more than 10 millimeter. And it is always important to recognize shock in the compensated stage. That is, whenever the heart rate is rising, then you must check that whether it is due to fever, whether due to shock, that you can easily check by seeing the peripheral perfusion. In young children, you can use the capillary refill time as an indicator, or you can see that the peripheries are cold if associated with tachypnea. So these are some of the ways how you can pick early compensated shock, and so that you can give early interventions and save the child. Now, this is a very simple chart which can help understand the cutoff according to the age. See, all these charts, the respiratory rate chart, then this hypotension chart, the heart rate chart, these are very simple, and they can be displayed in your pediatric COVID areas, and that can help in the management of the patients. So if it is a neonate, and then if the BP is less than 60, it is low. For children up to 1 year, if it is less than 70 mm, it is taken as low. And if it is a child 1 to 10 years, then this is a very simple formula that is used: 70 plus age in years into 2. And if it is less than that, then it is taken as low. Suppose a child is 5 years old, so you have to do 70 plus age is 5 into 2, 10. So 70 plus 10, that is 80 millimeter of mercury. If the blood pressure systolic is less than that, then it is taken as hypotension. And for, of course, 10 years, it is less than 90. So this simple formula can give you the cutoff of hypertension, even if you do not have the detailed chart. But then also, if you know this simple formula, and I think in most of the places, these formulas and these things will be displayed in the pediatric COVID wards for the ease of the non-pediatric colleagues, and so that the management becomes easier. So talking about the pulse oximeter, I think everybody has used at home and in adults, that we all know that it is measuring the saturation. Only thing, of course, the underlying conditions for which it is like measuring mainly the respiratory conditions, which we are bothered about in case of COVID. But of course, other illness like cardiac illness also will be indicated in this. Now, a saturation, what is the cutoff? If it is 95 and more, it is normal. So anything less than that should be evaluated and categorized, whether it is moderate illness, and if it is less than 90, it is severe illness, and what is the cause. Those things need to be evaluated. Now we know that this pulse oximetry, of course, we know that we all have read in physiology that it follows the sigmoid curve. I will not go into details. So, but we must understand that it is limited by the poor perfusion. Suppose the child is in shock condition, then unless the shock condition is improved and the child is having or cold peripheries due to hypothermia, very common in neonates that the peripheries are cold, maybe slightly cyanosed too, then this saturation will not be picked. So one has to be careful that the peripheral perfusion status should be good if we want this pulse oximeter to work. And if it is hyperoxia, then also it will not pick, because we know that the curve flattens in the upper part. Another thing that one has to be careful about the probes. We know the adult probes like pin-like thing, and it is taken in the fingers. But for the small infants, we cannot use with the same probes. And it has to be like a wraparound probe is there, which is separate for the neonates and the infants. And for pediatric population also, smaller probe size is there. And so while using, the machine remains the same. The pulse oximeter is the same, but it is the accessory, that is the probe that we are using, that differs in case of children. So this has to be taken care that whenever you are dealing with it, you must have this probe is there. Another thing that must be noted is that the position of the probe should not remain the same. Like after few hours, you must always change the position of the probe. That is the second thing. And third thing, probe has to be cleaned daily with 70% ethyl alcohol, which is very important. And whenever used in a different patient, it should be cleaned. So these things have to be taken care of while using a pulse oximeter. And of course, you have to see that the curve that is coming is proper or not. So if the patient is shivering, having high grade fever, then also you will not get these pulse oximeters. So be careful that when you are applying this probe, one, it is clean. Second, it is of appropriate size. That is for the neonate and infant, use the wraparound ones. Third, see that the peripheries are not cold and the perfusion is adequate. And also change the position when you are recording in few hours. So these things should be seen carefully. Now this approach is used for all children, but we will be applying it for the COVID patients only. That is, there are certain steps whenever you are evaluating a child. If the child comes to your triage, comes to the emergency, what are the steps to be taken? One is evaluate, then identify, and intervention. Now, this is the format that has to be applied in all children. We will be talking specifically for the COVID. Now, evaluation, the first part. Primarily, we'll be talking about the evaluation in this section, and identification. Interventions will be talked in the subsequent maybe lectures. So what are the things that have to be taken? Initial assessment, then primary assessment, secondary assessment. This is how we proceed whenever we come across a child in emergency or triage, and then the diagnostic text. Now, this is actually a small part. It's not very important. It is the clinical assessment. That is the most important thing that has to be followed. Now, this is the triangle. The first thing, now the evaluation, the first step that we are doing is the initial impression, what we get. Very simple, that only three things we are going to see. Appearance. Now, when you see a patient, when you see a child, if he's crying, active in the mother's lap, you'd see that the child is fine. Or if you see a dull child, lethargic, and moves only with maybe stimulation, that is, the child is lethargic. So by appearance, you are understanding that the child is sick. Second, after seeing the child, the appearance of the child, what we see? The respiratory rate. That we have already done, that we have to count it for 1 minute. We know the cutoffs. So we understand if a child is 8 months old and is having a respiratory rate of around 60, then we know that the child is having fast breathing. Then we see the color, whether the child is pale, maybe he's having shock, or cyanosed due to the underlying severe pneumonia, or maybe a cardiac condition. Now, how do we assess the central cyanosis? The best site is the tongue and the oral mucosa. In Indian children, it is best to be seen in the tongue. That if that is blue, then it is suggesting central cyanosis. So three things, quick three things: the appearance, the breathing, and the color. After this, then we go to this is the initial impression. Now we come to the primary assessment. This is your A, B, C, D, E. A, airway, we all know. Now airway is important because, and it should be open. Now how we open the airway? One, we place, in case of a small child, a neonate, a shoulder roll is placed. And this helps in extending the airway. Airway should neither be flexed nor it should be hyperextended. It should be open. Second, if we find that there is some secretion, how we open the airway? By suction. Suction is done for the mouth first and then the nose first. So these are the two things, how we open the airway. And then, of course, Doodle's airway can be used, but simple, by putting a shoulder roll or by doing a suction first the mouth and then the nose. Breathing. For the breathing, there are two parts. One, we have to assess the rate of breathing. That is, we have done that whether it is fast breathing or not. Then second is the work of breathing. How do we see the work of breathing? We have to see whether there is subcostal retractions or not. How do we see these subcostal retractions? That is the area. Can say the connection, the chest and the abdomen, that is the subcostal zone. And if you see that it is indrawing, going inside with the inspiration, that means that there is subcostal retractions. This is the most important sign to show increased work of breathing. Others are intercostal retractions, then suprasternal may be there, but the most important to show increased work of breathing in pneumonia is to see whether subcostal retractions are present or not. Then the saturation, of course. So three things will denote whether child is having some underlying respiratory, severe, moderate respiratory condition or not. Rate, if it is increased or is it normal. Work of breathing is increased or not increased. Saturation, whether it is normal, more than 95 or less than that. So these three things we have to see when assessing the breathing. Next is the circulation. Of course, heart rate, that we have already seen, that if it is more, we are more worried about the more heart rate, and also bradycardia. But here more because we have to assess whether the child is having fever, whether the child is having dehydration, whether the child is having shock. Then CRT, capillary refill time. The cutoff is 3 seconds. So it is 3 or more than that. That means the perfusion is poor. Blood pressure, we have already talked about. Peripheral pulses, we have to see whether it is weak, whether it is fast. So these things have again are an indicator of circulation. And next we see the color, whether it is cyanose, whether the child appears pale or not. Okay, so this completes our initial assessment where we saw the appearance, the color, and the breathing. Then again, in a detailed way, the ABC, that is airway, breathing, and circulation. And next, of course, if the child is unconscious, you have to assess the GCS scale or APVU scale. And then exposure. Always while examining, you have to see for few things, especially in COVID, like it had been dealt within the previous slide about the rashes, which may be present in MISC, the redness and the swelling over the hand and feet. So unless there is proper exposure while examining, these things will be missed. So that has to be seen. Okay, next is the secondary assessment. So initial assessments will be very fast. That is, you have to understand that all the vital parameters, all the A, B, C are appropriate or not. If we find anything wrong in those, then interventions have to be done there. Remember the format, that is first is the evaluate, then we have to identify, and then intervention. So if anything wrong was present in the airway, then that has to be managed. If anything wrong in this saturation, then oxygen has to be given. Similarly, if circulation is not adequate, then you have to give IV fluids or inotropes accordingly. So that has to be done initially. Next, secondary assessment, where we require a focus history and a focus examination. Now, focus history is pertaining to the COVID. What are the symptoms common that we have to take? We have to take about the fever, the running nose. Now, these symptoms can be present in any viral infection, but few things like GI manifestations will be more. Again, the positive history of contact of if there, we know that children get the infection from the adults only, in the family, in the schools, etc. So there has to be a history of contact of COVID infection. So that history is important. And of course, we have to go with a thorough head to toe examination. Now this diagnostic test then comes. So it's the least important, we can say. So what are the things? Of course, blood glucose is important because we know that hypoglycemia is damaging, especially in young children, may even produce seizures. So that is important. Then rest, of course, complete blood counts, electrolytes, ABG analysis, another important things, and LFT, RFT, coagulation profile may be deranged, and chest X-ray. Of course, since the symptoms are of pneumonia, so you need this chest X-ray. So these are the initial evaluation here is completed. So if we summarize this evaluation, we see in initial assessment, what is the sickness sign? Lethargic. Then fast respiratory rate, whether the child is cyanosed or showing poor perfusion signs. Then coming to the primary assessment, the thing that may be pointing towards grave disease is fast breathing, low saturation, less than 94%, increased in work of breathing shown by nasal flaring, chest indrawing, or presence of grunting. If there is tachycardia, hypotension, if cold extremities, again, these are all, and urine output, these all are showing your circulation. Then if the child is unconscious and the exposure may show the skin rash. Then the history, this we have already done. And of course, here when doing the secondary assessment, you must also look for the signs of dehydration, as the child may be associated with GI symptoms. Okay, now this is something that, yes, one must be very careful. That should prompt immediate intervention. One, if there is fever, for more than 3 days. That is abnormal and should be evaluated. Second, if the saturation is less than 94%. Third, if central cyanosis is present. Fourth, if the respiratory rates are more than cutoff for age. If chest indrawing or increased work of breathing is present, and features of MISC are present. So these are the red flag signs for the COVID infection. And there are general danger signs which have been given by WHO that if the child is not able to feed or breastfeed, if the child is vomiting everything, if the child is having convulsions or is lethargic, so these are the general which can be applied to all infections, all illnesses. And this classification is for the possible severe bacterial infection. And this particularly for COVID becomes important. Okay, so screening. Now, if the child comes to emergency, these are the things we have done. We have already gone through these things. And of course, we will do the sample collection for COVID apart from all the screening. Then this categorization has already been dealt. Now, how to categorize between mild, moderate, severe. This has been, I think, dealt in details in the previous. So just yes, fever will be present in all. See, respiratory rate fast will be in moderate and severe. Work of breathing will be increased only in severe. Cyanosis may be present in severe. See, saturation becomes very important. Like for severe, it is less than 90%. For moderate, it is 90 to 94%. And mild, it will be more than 95. So this SpO2 is very important. Circulatory insufficiency, we have already talked, how do we assess, and is present in severe cases. Again, general danger signs will be present in severe cases. So we have identified our severe COVID infections. We have identified who are moderately sick and who are mild. So this assessment helps us to triage the COVID patients, categorize them. Of course, there is some comorbid conditions which, if present even with the mild, may require admission, like if the child is a child with diabetes, with cardiac or chronic lung, chronic kidney, chronic liver disease, neurological disorders, is severely malnourished, or is on immunosuppressive or steroid therapy, or having cancer, then if these comorbid conditions are present, even children who are having mild symptoms may require admissions. So what is the type of facility based on the admissions? Of course, if the child is asymptomatic, mild, it has been talked in the previous that home isolation is possible in the absence of comorbid conditions. If with comorbid, then of course it needs to be admitted, maybe in isolation facility. Moderate illness in COVID, HDU, and severe, of course, COVID ICUs, PICUs. MISC if present, then in non-COVID PICU and HDU have to be managed. So to conclude, assessment of vital signs is critical and age-appropriate cutoffs should be known. Recognizing a sick child can be done easily by a structured approach, and evaluation comprises of initial assessment, primary assessment, and secondary assessment. COVID-19 patients can be classified into mild, moderate, and severe cases based on this evaluation. And red flag signs, the general danger signs, and comorbid conditions must be assessed. And I would like to thank, and these are the references where it has been taken from. And of course, we have to skills that can be enhanced is that we can practice counting the respiratory rate and the blood pressure, recording the temperature, using pulse ox in a child. And my sincere thanks to all those who have helped preparing these slides. So thank you.
Thank you so much, ma'am, for such a lucid presentation. I hope everybody is now familiar how to recognize these children, how to monitor the vitals and the triage while managing these children. So I would request ma'am to take up few questions which are in the chat box.
Okay, I'll just go through them.
Yes, ma'am.
I think I cannot find the questions. Or maybe I can type it.
Yes, ma'am, you can do that.
I can type the answers subsequent. You can
Yes,
start with the next
yes,
session.
ma'am. So moving further, I would like to call upon Dr. Shitanshu Srivastava. She is a faculty in RML Institute of Medical Sciences, Lucknow. She will be talking about management of mild COVID and monitoring during home isolation of these patients. I welcome you, ma'am, and over to you.
Thank you so much, Dr. Arpita. And it is indeed a privilege to be presenting to a August audience. I can see there are around 800 participants, and all logged in since. So this talk is very short because the background has already been set, and with good lectures before, and the previous lecture also encompassed most of the things. So it would be just a reiteration of what has been done, but not less. It is a very important part because that is what we saw basically in children in the last two waves. So it is quite an important thing to be monitored. Is my screen visible?
Yes, ma'am.
Okay, just a moment. It has
Yeah, it's
lagged out on my part. Just a
Yes,
moment.
ma'am, it's gone. Yeah, it's come again, ma'am.
Okay. So these things have been beautifully taken up before about mild COVID and how to monitor them. So now I would be briefly, very briefly talking about the management of the mild COVID and monitoring during home isolation. So I'll be just highlighting the important points in this. So the learning goals would be the clinical features of mild COVID infection in children. Home isolation, what would be the feasibility? Because that is also important. Symptomatic treatment, what should be given? Treatment of the child with comorbidities, if any. The red flag signs already have been discussed, and again, I will stress on those points because they are very important. What are the do's and the don'ts and the home monitoring? In home monitoring. So these would be my learning goals. So the mild cases. So we start with the clinical features. So what would be the clinical features? As very lucidly discussed already, the child will be having fever. So that is a very important part. And how do we measure fever? We have come to know all those nitty-gritties of that. So one is a very important clinical feature, that is fever. Again, sore throat in the child will be a symptom. The child may not present with the sore throat also, but these are the common symptoms that are there. So fever with or without sore throat, rhinorrhea, that is running nose, cough may or may not be present, and diarrhea and vomiting, that is the GI symptoms. So they might be accompanying, the child might have some GI symptoms as well. But the most important part is the child will not have fast breathing. It has been discussed very elaborately before. What are the criteria of fast breathing? So the child in this situation, in a case of mild COVID, the child will not be breathing fast. So that is a very important thing. And the criteria is very well known to everybody. That is the 60, 50, 40, and 30 cutoff, starting from 2 months, 2 months to 1 year, 1 year to 5 years, and more than 5 years. So that would be the main clinical features which the child would be presenting. So fever, as discussed, more than 38 degrees centigrade, or in Fahrenheit, it would be 100.4 degree Fahrenheit, which would be the auxiliary temperature. So that would be this is just a pictorial presentation to make it more interesting. Sore throat, again, rhinorrhea and cough the child will be having. GI symptoms the child may have, and in the second wave we saw a lot of children with GI symptoms only along with fever. So definitely this can be there. So how do we proceed further? So we know the clinical features now. So how do we proceed further in the management of mild cases? So these definitely, as the word signifies, mild. So they can be managed at home without panicking, and they should be realized by the clinician as well as the parents. So the first important integral pillar would be the home isolation. That is very important. And the second thing is symptomatic treatment, of course. So what is the feasibility of home isolation? So home isolation is that has been clearly defined by the various guidelines, MOHF guidelines. So we have to be very careful, and the feasibility part should be met for this. There is a requisite facility for isolation at his or her residence, and also for quarantining the other family contacts. So this is an important. So there should be a facility at home. Parents or other caregivers who can monitor and take care of the child. So there should be one caregiver, preferably a parent only, who will be taking care of the child. So that is also important. If available, Arogya Setu app should be downloaded. So because it is a app which uses the internet, so this is a preferable app the family should have, so that the child can be enrolled in that app. Then the fourth point in the home isolation feasibility is the parents and the caregivers has agreed to monitor the health of the child regularly. So this is also very important. The child cannot be left at home in isolation without any monitoring. So the parents have to agree, and this has to be done, and regularly inform his health status to the surveillance officer or the doctor in charge. So this parameter is one of the most important parameter which should be met. Suppose the parents themselves are suffering from COVID, in that scenario, it would be difficult for them to monitor. So there has to be a caregiver who would be monitoring the child at home, and he will be informing to the surveillance officer or the doctor concerned. Then the parents and the caregiver has filled an undertaking. So they have to fill an undertaking. So first they have to give the consent, and definitely they have to fill an undertaking on self-isolation and shall follow home isolation and quarantine guidelines. So these are the important parameters of home isolation feasibility, which should be met before proceeding further. And the most important thing is why this feasibility is there, because sometimes if this is not there, the child may land up into that mild COVID, he may land up into that, might progress and land up into moderate or severe COVID. So that part is very important, and this is a very crucial point. So that is why this feasibility thing should always be met. So what is a symptomatic treatment? We all know that treatment of mild illness in home isolation is symptomatic, of course. It is for fever. Paracetamol 10 to 15 mg per kg per dose may be repeated every 4. It can be repeated as early as 4 hourly. Even 15 mg per kg per dose can be repeated at a 4 hourly interval. Quite safe. That counseling has to be done. For cough, throat soothing agents like warm water can be given, saline gargles for older children and adolescents. So this is a very important parameter, because once the child is having a slight cough, even the parents insist on a cough syrup to be given. So we should be aware, like as a treating clinician, as treating doctors, that cough syrup should be avoided in all circumstances, not only in COVID, but otherwise also, in lieu of the various constituents which are might sedate the child. Number two, the combinations are sometimes not rational, and most of them are not approved also. So cough syrup should be avoided, and frequent warm water sips can be given to smaller children, and saline gargles if possible older children, and of course they can also sip warm water, which will soothe the throat and allay the symptoms of mild cough. So then coming to the fluid and the feeds, ensure oral feeds to maintain hydration and nutritious diet. So this is very important. So regularly the child must be taking oral fluids. So hydration has to be maintained. Because we know with fever also dehydration sets in. So the child needs more water at that time when the fever is setting down. So the child needs extra oral fluids, and it could be just plain water. So that can be given, and of course a nutritious diet should be given to the child. So coming to the child with comorbidities, a child who is having mild fever along with no respiratory symptoms with what should we do in that situation? So he may be managed at home, but again that criteria of feasibility should be met, the undertaking should be taken, and children like congenital heart disease, chronic lung diseases, chronic organ dysfunction, and obesity, so they may be managed provided they are monitored properly, and the surveillance, the condition is reported regularly to the surveillance officer. So that is a criteria. and they can be admitted if there is any deterioration in the symptoms or lack of proper arrangement to manage at home, or access to health facility is difficult, because in a situation the access to the health facility is quite cumbersome or difficult. Even though the child is having just fever or mild symptoms, he might need admission. Because this is an important parameter which all the clinicians should know about. So what are the criterias and how the home monitoring should be done? And the most important thing is, what are the do's and the don'ts? So that is very important for all of us to remember and know. So monitoring at home. So again, the counseling thing, we all know, explain to the parents, caretaker, how to do it. So this is important. And these are all objective management protocols which have to be followed in black and white. So this is a very important thing. So maintaining a monitoring chart. So I will show you the monitoring chart also, which has to be given to the parents. So what are the criteria which have to be monitored? Of course, counting the respiratory rate 2 to 3 times a day while when the child is not crying. This is important. When the child is crying, again, it will not be a reliable, because at that time it cannot be interpreted reliably with reliability. So what we have to do, when the child is not crying and yes, the rate has to be counted. And one more important thing, if the child is febrile, again the respiratory rate would increase by to the tune of 10. 1 degree centigrade rise would increase the respiratory rate to 10 times. So that is also a very important criteria which should be kept in mind. So look for chest indrawing, nasal flaring. Of course, these are signs of a little more than a mild symptoms, because now the infection has set into the chest, and the child presents with chest indrawing and nasal flaring. We have all seen such children in various scenarios. Bluish discoloration of skin and lips, again a sign of severe COVID, but we have to monitor this sign, whether this sign is present or not, and if not present, we have to cross it. Then cold extremities, as already been discussed, again a feature of shock. Then these were some severe features which needs to be monitored. Again, fluid intake, activity level, especially for young children. So these are a very important parameter in young child. What is the activity level? The child is playful, he is feeding well, he's taking oral feeds normally. So if those things are there, of course they have to be monitored objectively on the monitoring chart. So this was about the activity level. Then the urine outputs. If the fluid intake is good, of course, then the urine output would be good. So the child should pass around 6 to 8 times urine, and he should be passing in a young child. So that has to be monitored. Otherwise, also the child should be passing urine. Older children also should be passing urine 4 to 5 times at least, along with a good fluid intake. So this has to be monitored objectively on a monitoring chart. Again, the nitty-gritties of taking the oxygen saturation has been already been discussed, and they should be taken again by a handheld pulse oximeter, and more than 94% is desirable. Less than 94 is an alarming sign, and which should be immediately communicated to the surveillance officer. And there should be a regular communication to the doctor or the healthcare worker. Parents, caregivers should be explained whom to contact in emergency. So all these things should be in handy. Again, if the child, there is any deterioration, those things should be done immediately. So objectively, as I told, so again, summarizing all those points, we have to count the respiratory rate for whole 1 minute for at least 2 to 3 times in a day. We have to look for what? We have to look for chest indrawing, nasal flaring, whether present or absent, cold extremities, activity level, feeding, and hydration again. So objectively, these points have to be there. What we have to measure again? We have to measure the temperature and the SpO2. Again, 2 to 3 times, 3 to 4 times, in fact, not less than 3 times in small child, they should be monitored. So this is the monitoring chart which has to be filled, and we can see here all these parameters are there. A point of GI symptoms have been added, like if any symptom sets in, like suppose the child started with fever and now a new symptom has set in, that they can also add, but objectively they have to measure all these points. And as we can see, 3 times a day it has been written, and 8 a.m., 2 p.m, and 3 times at least it has to be done, not 2 times, 3 times at least in a day. So now what are the don'ts? Like the child is only having mild fever with no other things, or he might be having some GI symptoms which are manageable at home, and the child is otherwise active and playful. So what things we don't need to do? Apart from monitoring, we do not need any investigation. Please, this is a very, very important point. There is no need of a chest x-ray or any other investigation which comes in the mind of the parents or other caregivers immediately ki we should go for something, we should investigate the child. There is no need for that. No need for chest x-ray or CT chest. Antibiotics, what is the stand on antibiotics? We know COVID is a viral infection. So is the role of antibiotics is not there at all in the initial stages of mild COVID. The other things, when some biotics are required, would be discussed later, but definitely not in mild COVID. Children will not require any antibiotic, even if he is running fever for continuous 3 days. So that has, this point also has to be uh, stressed. Steroids again not indicated in such a scenario. Known role of hydroxychloroquine and all these fancy drugs which are available, which were used for severe COVID, and their role has also been doubtful in children as well. So please, there is no role for all these drugs in mild COVID, of course. So now coming to the red flag signs, which you already told. So the red flag signs should be kept handy, and they should always be, everybody should know ki what are the red flag signs. So persistent fever for more than 3 days. Again, the child is running high grade fever and it is not setting in. So and this is actually not high grade, this is 100.4, this is something mild fever. But if he is running for more than 3 days, so along with this, any other sign like fast breathing, which is 60, 50, 40, and 30, which we know that fast breathing sets in, and the SpO2, that is the saturation, which is less than 94. So we have to be cautious, and these are the red flag signs. We have to be very cautious. We have to report what is the clinical condition, and the child might need hospitalization. Then the other red flag signs are persistent drowsiness, lethargy, poor feeding. These are also very important parameters, clinical parameters, which we always rely in young children. So poor feeding, mother complains the child is not feeding well, the child is lethargic, जितना वो बच्चा खेल रहा था अभी खेलना बहुत कम कर दिया, सो रहा है पूरे दिन. Drowsiness, cold extremities would be a later sign, that is a sign of shock. Urine output at least 6 times, 6 to 8 for infants we count, in smaller children or infants. Older children, it could be a little less, but the urine output should be adequate as the child was passing previously. Skin rash, red eyes, uh, uh, this is a very, very important criteria. The awareness of this criteria is very important at all levels, because of the term, something like called MIS-C, which we saw a lot, a surge of patients. So whenever a skin rash sets in a child with fever, it is considered as a red flag sign. The child should immediately be contacted with the surveillance officer or the doctor for adequate action. Why? Because that means that multiple system involvement has set in, and it could lead to further problems. So, and the management also will be discussed later on. So we have to be very cautious, and at every level the history of rashes and red eyes should be uh, stressed at every point. So this is important criteria. Again, bluish discoloration of the lips, again that would be cyanosis. That is a late sign which sets in when there is severe symptoms have set in. So this was a very a short these are the various references which I have taken from. And before that, the skills which needs to be enhanced is the temperature assessment. This is a very important, because when we practically go to the take the temperature of a small child, there are a lot of difficulties. So this is important: counting respiratory rate, how to assess hydration status, and recognizing the red flag signs. So these are the important skills which needs to be actually worked on and enhanced. And sincere thanks to all the contributors for making these PPTs. Thank you so much for giving me the opportunity. Thank you so much.
Thank you so much, ma'am. That was an excellent talk. And I would request the audience, if they have any queries, they can write in their chat box or in the question answer box. And let me check if there are any questions. None that I can see, ma'am.
Okay.
So
if there are any, I would type them. So I think we can proceed. Thank you so much, Arpita.
Thank you so much, ma'am. So we proceed, and I would like to announce that we can all go for the lunch break. It will be a very short lunch break for 20 minutes, and we can meet again at 2:45 like that. So I would request everybody to stay with us and do join us at 2:45 p.m. And there will be a talk by Dr. Ghanshyam Chaudhary, faculty at GMC Jalon. He'll be talking about management of moderate COVID in level 2. So he will be joining us post lunch. Thank you so much, and do join us on time. We will start sharp at 2:45. Thank you.
So a very pleasant good afternoon to one and all present here. Am I audible and my slides are visible?
Yes, sir.
Okay, thank you, madam. So happy Janmashtami to one and all. So topic allotted to me is management of moderate COVID in children at level 2. Many things we learned from morning, so something are repetition in this lecture and some new things are also here. So my learning goals are: we should assess the severity of COVID in children. We will also discuss about the management of moderate COVID in children, whether we should manage them in hospital or at home-based management. Management is a very important step of management is monitoring. So how we should monitor moderate COVID children? How we investigate moderate COVID children, whether investigations are required or not, we will discuss here. Fluid requirement, whether fluid is required or not, how to give fluid either orally or through IV, we will discuss here. And how to give oxygen, we discuss about the oxygen therapy in moderate COVID children. So before assessing the severity of moderate COVID in children, first we discuss about the how we diagnose. We have discussed, we learned many things since morning about the investigations, how we diagnose COVID in children. So whenever any case comes, suspected case, with features of influenza-like illness, fever, rashes, loose motion, vomiting, abdominal pain, etc., we go for antigen test. And if antigen is positive, then it is confirmed case of COVID. If it is negative, then we go for RT-PCR. And if RT-PCR is positive, then it is confirmed case of COVID-19. If it is negative, then it is non-COVID case. But if there is a strong doubt about the COVID, we can repeat RT-PCR or we can go for CT test. How we assess severity, how we classify moderate COVID in children. So we divide COVID in children in 4 categories: mild disease, moderate disease, severe disease, and critical disease. In mild disease, there is sore throat, rhinorrhea, cough, loose motion, vomiting, pain abdomen, etc. But there is no fast breathing. So any child with these symptoms during epidemic of this COVID-19, we suspect case as a mild disease. But if along with these symptoms, child is having fast breathing, then it is moderate disease. And fast breathing is defined as respiratory rate is 60 or more per minute for children less than 2 months of age. In children between 2 months to 12 months, if respiratory rate is 50 or more, then it is tachypnea. In children between 1 to 5 years, if respiratory rate is 40 or more, labeled as tachypnea. Children above 5 years, and if respiratory rate is 30 or more, it is tachypnea. And in these children, SpO2, oxygen saturation, is between 90 to 94%. And another thing is there should be no sign of severe pneumonia. So in moderate disease, only mild symptom plus tachypnea and mild desaturation, desaturation between 90 to 94%. In severe disease, presence of moderate disease along with any one of these are in combination. That means presence of cyanosis, oxygen saturation below 90%, increased respiratory efforts that can be detected by presence of grunting, severe chest indrawing, chest retractions, lethargy, convulsions, child is unable to take any feed and vomits everything. If any one of these are in combination present, it is labeled as severe disease. Critical disease is if child is having presence of ARDS, acute respiratory distress syndrome, evidence of sepsis, septic shock, multi-organ dysfunction syndrome, acute thrombosis, MIS-C, multi-system inflammatory syndrome in children. So if these are present, any one of these is present, it is critical disease. So today I will discuss moderate disease. Mild is already discussed in previous lecture. Severe and critical disease will be discussed in coming days. How we manage moderate COVID in children? Ideally, all moderate COVID children should be hospitalized, and they should be hospitalized in dedicated COVID facility. And moderate COVID children should be admitted in HDU. Whereas severe cases should be admitted in PICU. Management is nothing, only supportive along with oxygen therapy. So oxygen is mainstay of the treatment along with other supportive treatment. But monitoring is very, very important because they deteriorate very rapidly. So moderate COVID cases should be monitored 4 hourly. And if they are rapidly progressing, then we can monitor even more frequently. Things we should monitor is sensorium that can be monitored by ABPU scale. A stand for awake, B stand for command following the voice command, U stand for unresponsive, P stand for response on pain. So ABPU scale. Then we monitor pulse rate, pulse volume, respiratory rate, any evidence of respiratory distress that can be detected by presence of retractions, head nodding, nasal flaring, etc. We also monitor blood pressure, oxygen saturation, liver size, urine output. So these things should be monitored at least 4 hourly in all moderate COVID children. Investigations. We should not do all the investigation in all children, but some primary investigations should be done in all moderate COVID children, like complete blood count, liver function test, renal function test, C-reactive protein, X-ray chest, blood sugar, and blood culture if suspecting bacterial infection. But if child is not improving and rapidly deteriorating, then we should go for other investigations also, like coagulation profile, monitored by PT, APTT, D-dimer, serum ferritin, procalcitonin, CPK, ECG, and echocardiography. Other supportive management is fluid. Whether we should give oral fluid or IV fluid. So we should prefer to give oral fluid if child is able to take and child is not having much vomiting. So if child is able to tolerate oral feed, we should prefer to give oral feeds. If child is on breast milk, we give breast milk. If child is on other milks, we give that or homemade fluids. But if child is having dehydration, because many of the children are presenting with loose motion vomiting. So if child is having dehydration, we should assess the dehydration by WHO criteria, and we classify in 3 groups: no dehydration, some dehydration, and severe dehydration. And we manage according to WHO plan. Plan A for no dehydration, Plan B for some dehydration, and Plan C for severe dehydration. If child is unable to take orally or poor oral intake, in those children we prefer IV fluid. But what amount of the fluid should be given, that can be calculated as, if child is infant, that means less than 1 year of age, we calculate 150 ml per kg per day. And this fluid is maintenance fluid. In children above 1 year, 120 ml per kg for first 10 kg. Then for next 10 kg, 50 ml per kg. And for next 10 kg, 20 ml per kg. So suppose a child is of 25 kg. So for 10 kg, first 10 kg, we multiply by 10. So it will come 1200 ml. For next 10 kg, we multiply by 50. So it will come 500, total 1700. And for next 5 kg, we multiply 5 by 20, it will come 100 ml. So for 25 kg child, maintenance fluid is 17 plus 100 is 1800 ml in 24 hours. But along with this, if child is having any type of dehydration, like no dehydration, some dehydration, or severe dehydration, we add additional fluid. And if child is having more losses, having more vomiting, more stools, so we add some fluid for concurrent losses also. What type of the fluid should be given in these children? Preferably N/2 with dextrose. And if it is not available, we can prepare half of the volume of 10% dextrose and half of the volume of normal saline. So this fluid is preferred in children with moderate disease if hospitalized and not able to take orally. Other fluid that can be used is DNS that contains 5% dextrose with normal saline. But we should add potassium chloride if we are going to give fluid for more than 24 hours. And potassium chloride should be added, we should add 1 ml of potassium chloride in 100 ml of the fluid. Isolate P previously we are using, it should not be used because it is hypotonic. Next supportive management is control of fever by antipyretics and control of vomiting by antiemetics. So antipyretics, paracetamol is drug of choice. So first choice is paracetamol. Dose of paracetamol is 15 milligram per kg per dose, maximum 4 times a day. And preparations of paracetamol available, it is available in form of drop, syrups, double strength syrups, tablets, and injections. So preferably most of the drops, 1 ml of the drop contains 100 mg of paracetamol. Most of the drops, some contains 150 also, but most of the paracetamol drops contains 1 ml 100 mg of paracetamol. Syrup of 5 ml of paracetamol contains 120 mg of paracetamol, but double strength syrup 5 ml contains 250 mg. Second choice is ibuprofen and dose is 10 milligram per kg per dose. It is also available in syrup tablet forms. And syrup of paracetamol, this ibugesic, ibuprofen, 5 ml contains 100 mg. Third choice is mefenamic acid. It is given in 10 to 25 milligram per kg per day. And fourth choice is combination of paracetamol and ibuprofen, available by the name of Combiflam, Flexan, ibugesic plus, etc. Then next is antiemetic. Antiemetic we can use domperidone. The dose of domperidone is 0.2 to 0.4 milligram per kg per dose. It can be given 3 to 4 times per day. It is available in syrup form and drop form. Syrup of domperidone contains 1 mg per ml. Second antiemetic is ondansetron. It should be given at by the dose of 0.1 mg per kg per dose. It can be also given 3 times a day. And 5 ml of ondansetron syrup contains 2 mg of ondansetron. Antibiotics, as we all know that COVID is a viral disease and antibiotics are not antiviral. Most of the antibiotics are not antiviral. So there is no role of antibiotics in COVID-19. But if there is strong evidence or strong doubt about the bacterial infection, and that can be evident by investigations, we can use antibiotics. And the choice of antibiotic is amoxicillin. The first choice is amoxicillin. Dose of amoxicillin is 30 to 40 milligram per kg per day in 3 divided doses. So preferably we should give syrup. It is also available in injection forms. We can upgrade it to amoxicillin plus clavulanic acid or in combination with ceftriaxone and other antibiotics. Other supportive measure is nebulization. Nebulizations, conventional nebulization should be avoided in children with COVID. It is indicated if there is wheezing is present. Traditional nebulization should be avoided because it generates aerosol and that spread infection more rapidly. We should preferably use meter dose inhalers, MDI, with spacer and mask like this. So if there is wheezing, we should avoid nebulization if these are present. Meter dose inhalers, spacer, mask of appropriate size according to age of the child. And drug we should use is asthalin inhaler. That one puff contains 100 microgram of salbutamol, or Libolin inhaler is available also that contains 50 microgram per puff. And we can give 2 to 3 puff every 4 to 6 hours. But if MDI is not available and it is not feasible, then we can use conventional nebulization, but we should cover the face of the child after this nebulization mask. Above that, we can use triple layer surgical mask. So avoid spread of aerosols. Drug that we can be used in nebulization, asthalin respiratory solution, it is concentrated. So 1 ml of this asthalin respiratory solution contains 5 milligram of salbutamol. And for nebulization, we use 2.5 milligram of this salbutamol. So we use 0.5 ml of this asthalin respiratory solution, and we add 2.5 ml of normal saline in this nebulization chamber. So for nebulization with asthalin respiratory solution, 0.5 ml of asthalin respiratory solution and 2.5 ml of normal saline can be used. It is also available in respules that is already diluted, and it comes in 2.5 ml quantity. So 1 ml of this asthalin respule contains 1 mg of salbutamol. So 2.5 ml total can be used in this chamber and can be nebulized without dilution. Then comes oxygen therapy and its mode. Oxygen is only indicated if there is desaturation, that means oxygen saturation below 94%, and or there is increased distress. Target of maintaining oxygen saturation is above 94%. We can also try awake proning in case of desaturation, and that can be tried in moderate cases. Mode of oxygen therapy in moderate disease is by nasal prongs, face mask, and non-rebreathing masks. So these three modes can be used moderate COVID pneumonia in children. Other mode of oxygen therapy are HFNC, heated humidified high flow nasal cannula, CPAP, BiPAP, and invasive ventilators. So these four modes are used in case of severe COVID pneumonia. So in moderate, only these three modes, nasal prongs, face mask, and non-rebreathing mask can be used. Coming to first, that is nasal prong. It is available in different size, 3-4 sizes: neonatal, pediatrics, neonatal, infant, pediatrics, and adult. So like this. And oxygen flow can be given by this means is 0.5 to 4 liter per minute. We cannot give more than 4 liter per minute by this. And FiO2 that can be delivered by this is 30 to 40% of oxygen. So if child is having mild distress, we can use this. Other mode of oxygen therapy is by face mask. It is also available in neonate, infant, pediatric, and adult size, R0, 1, 2, and 3 sizes. Oxygen flow that can be given by this is little higher. It is from 5 to 8, 9 liter per minute. And oxygen FiO2 is also delivered little higher than the previous mode, that is by nasal prong. So by this mode, simple oxygen mask, we can deliver FiO2 30 to 60%. The third mode of oxygen therapy in moderate COVID children is non-rebreathing mask, or also known as reservoir mask. So it is also available in different sizes, neonate, infant, pediatric, RS, M, and L size. Oxygen flow that can be given by this is more higher than the previous modes. So it is from 9 to 15 liter per minute. And FiO2 delivered by this is also much higher than the previous modes. It is from 40 to 90%. So in first mode by nasal prong, we deliver 30 to 40% of FiO2, and we use 0.5 to 4 liter of oxygen per minute. In second mode by conventional oxygen mask, we use 5 to 8 liter of oxygen flow, and we deliver 30 to 60% of FiO2. By this means we deliver 9 to 15 liter, we give 9 to 15 liter per minute oxygen flow and deliver 40 to 90% of FiO2. Then coming to steroid, low molecular weight heparin and remdesivir. Steroids are not recommended in moderate COVID children. It is recommended only in severe and critical children of COVID-19. So in moderate COVID, steroid is not recommended. Anticoagulants, low molecular weight heparin, is also not recommended for prophylaxis in any disease severity. Even in severe cases, also not recommended for prophylaxis. But it should be used only if there is established thrombosis, evidence of thrombosis is there, then we can use this. And dose of this low molecular weight heparin, that is coming in by the name of enoxaparin, 1 milligram per kg per day subcutaneous, once daily for 10 days. So enoxaparin can be used if there is established thrombosis or evidence of thrombosis, not according to disease severity, and dose is 1 milligram per kg per day subcutaneous, once daily for 10 days. Next comes remdesivir. It is also not recommended in moderate disease, but if there is evidence of rapidly progressive disease and child comes before 7 to 8 days, then it can be used. And dose of remdesivir is in children above 40 kg is as in adults. On first day we give 200 mg, and for second to fifth day we give 100 mg per kg, 100 mg daily. In children below 40 kg, we give 5 milligram per kg on first day, followed by 2.5 milligrams from second to fifth day, once daily. Drugs like favipiravir, tocilizumab, hydroxychloroquine, chloroquine, ivermectin, azithromycin, lopinavir, ritonavir, etc. are not recommended for routine use in any disease severity. It is also not recommended for prophylaxis. What are the discharge criteria? Moderate COVID disease in children can be discharged after 10 days of onset of symptom, but there should be clinical resolution of the symptoms, and child should maintain saturation above 95% for at least 3 days without oxygen. And we should advise home isolation for 7 days and follow the child. These are my references: Ministry of Health and Family Welfare, Indian Journal of Pediatrics, Lancet, BMJ, etc. A skill that can be learned from hands-on training is recognition of danger sign and assessment of the severity of the disease. And a skill of oxygen therapy, modes of the oxygen therapy, that can be learned from the hands-on. So thanks to all contributors, DGME sir, DGMH, KGMU, SGPGI, RML, Lucknow, IMS BHU, AIMS Raebareli, SSPH Noida, SRMS Bareilly, Chandkanta madam, Sally madam, Prajapati sir, all for giving me opportunity to talk so many intellectuals of the state. Thank you one and all present here for your patient listening. If any question, I will answer in chat box and question answer box. So coming to the next talk, next speaker is Dr. Neeta Radhakrishnan. She is Associate Professor in SSPH Noida, and she is going to talk about the X-ray in children, X-ray in COVID children. Over to you, madam.
Thank you, sir. Audio is okay, right, sir?
Yes, ma'am.
Thank you, sir. Good evening, everybody. So the next session, the last session for today, is on interpretation of chest X-rays in the scenario of pediatric COVID-19. Some of the images and tables have been taken from literature. The sources have been cited. So what is the overview of today's session? One, we will see how this X-ray, that is pediatric X-ray of a pediatric patient in a COVID scenario, how is it different from our routine X-rays? Two, we will see how to report a pediatric X-ray, what are the normal outlines, landmarks, and what is the format of reporting. Three, we will see what are the X-ray abnormalities of concern in COVID-19. And fourth, we will see when should we order X-rays in children and whether there is any requirement for CT scans also. So this is the format. So we'll start with how this X-ray is different in a COVID-19 scenario compared to otherwise. So routinely in an OPD or an emergency practice, when a child comes for an X-ray, that is a child with mild respiratory or moderate to severe respiratory distress, we generally get an X-ray done from the X-ray department, a radiology room, where the child is sent and the X-ray is taken. Only if the child is ventilated or something, we ask for a portable X-ray. Here in the case of COVID-19, usually when the child comes with we've been hearing since morning that when a child comes with respiratory complaints and if there is a COVID wave happening, and we have been asking for COVID test initially, and then they come with the report. So when they come with the report, that is when they get admitted to a pediatric COVID facility. So once they get admitted to a pediatric COVID facility, we will not be sending them back to the radiology department for an X-ray. We generally will ask for an X-ray there itself, and that is the first difference. So that we will be ordering a portable X-ray in most cases. Very few patients would be admitted in a holding area or a pediatric ICU, have an X-ray and later turn out to be COVID-19. That is different. But usually they will be admitted and then we ask for an X-ray. Two, there are children who've been admitted in the COVID-19 ward and been started on treatment. By day 2, day 3, there is no improvement or there is a sudden deterioration, in which case also we repeat an X-ray. So all these cases, it's a portable X-ray that we are taking. So portable X-rays are AP projections, and because of which there will be slight difference in the size of the heart. The heart looks a little larger than normal. So because the cardia being an anterior organ, so there is slight magnification in AP projections, and because of which we are not supposed to be reporting cardiomegaly from AP films. One. The second difference is that since we are not sending it down to the as in we are not sending it to the radiology department or our radiology colleagues for reporting, we are supposed to be knowing the basic format of reporting and what all to expect, and we are to be taking decisions based on these X-rays also. So that is the second difference, that most of it is a decision which is made by the clinician who is on duty there, be it the resident or the medical officer or the faculty, whoever is on call and is responsible is supposed to be making decisions. So these are the two differences in a pediatric COVID scenario. What are the differences for the pediatric X-ray itself? One, I told you AP projection, the heart would look a little larger. Second, many times children are crying. They won't be able to hold breaths. As it is less than 6 years, 7 years, we won't be asking them to hold breath also. So because of which, if it is an expiratory film, again, there will be an apparent cardiomegaly. So because of which, we should not be reporting cardiomegaly in these X-rays. If at all we think there is a massive cardiomegaly or if we think there is a cardiac involvement, better to get an echocardiography done. Third, small babies will have thymus, which is prominent. So thymus is an organ which is there in the superior mediastinum, and this can be very prominent till around 5 to 6 years of age, especially in the age group of infancy and for 1 to 2 years. Whenever there is an infection, especially a viral infection, thymus can look larger than normal, and that can look like a upper zone consolidation or a mediastinal mass, etc. So we should be knowing what it is and rather than raising panic. And finally, because it's an X-ray of a child who is sick, majority of children have to be restrained while the X-ray is taken. They'll be crying. There will be some amount of rotation. So we should look at the film for rotation as well. And if it's a badly rotated film, then we should not be commenting on the lung parenchyma based on the rotated film. So these are the main 4 differences of a pediatric X-ray. Let us see when we get an X-ray in our hand, let us see if this X-ray is worth reporting or not. So first of all, we look at the PA or AP projection. Both are fine for reporting as such. It's just that cardia should not be reported on an AP projection. So here you can see the spine distance. The spine and the interspinous distance is very clearly seen. So this means that it is a PA projection, whereas AP projection. PA views, we don't see it, so we can just make out the vertebral borders in a PA view, which is what usually we ask for. Second, we look at the penetration, how good or how exposed is the film. If it is an underexposed film, we should not be reporting lung parenchyma on underexposed film. How do you know it is an underexposed film? The lung shadow looks very dark. So it almost looks like the emphysematous X-ray of emphysematous or COPD adults. So we don't see that kind of emphysema-like picture in children at all. So if an X-ray is looking unduly black lungs and the lung markings are not clear at all, so that means it's an underexposed or an underpenetrated film, in which case we should not be commenting on lung parenchyma. 3. We look at whether it's an inspiratory or an expiratory film. Ideally, lung parenchyma should be reported on inspiratory films. So how do you know if it's inspiratory or expiratory? We look at the posterior border of the rib. I'm trying to mark out the posterior border with the arrow here. So these are the posterior border of the ribs. So usually more than around 7 to 8 posterior border of the ribs are very clearly seen. So here let us mark out, this is 1, 2, 3, 4, 5, 6, 7, 8, 9. See, it's a very good inspiratory film. And the second way we know that is whether the diaphragm are like almost flat. So that means the diaphragm is pushed down because of the lung being in inspiration. So this is a good film to report your lung parenchyma. What happens in expiratory film? It will be around 4 to 5 ribs only that you can see. And the dome of the diaphragm will be like this. It will be pushed up because it's an expiration. In that case, you won't be able to see if there are there is consolidation. You won't be able to appreciate it well, and hence it is better not to report on an expiratory film. And finally, we look at rotation. So what do we look at rotations? In rotation, we see whether the trachea is central and the clavicles are symmetrical. So clavicles, we have 2 clavicles, they should look equal compared to each other. If you draw a line in the midline, the clavicle should be symmetrical on both sides. So if we find that it is a good X-ray, so this is a reasonably good one. There is slight asymmetry, but then that is fine. So when the clavicles are symmetrical to each other, the trachea should be in the midline or slightly to the right. So this is also okay. So this is an X-ray which is good for reporting. Suppose it's a highly rotated film, again, it can underestimate or overestimate things. It's like, for example, if it's a rotated film, you may miss out on some pneumonias. You may overestimate. Sometimes there can be false lucencies that can come up. So that can actually overestimate pneumonia. So then that way also, if it's highly rotated, better to. So these are all very easy because if you have a portable X-ray, you're getting the film within few minutes time. So when you get the film, see it immediately and tell whether you need a repeat or not. If you don't need a repeat, proceed with this. And we try not to repeat as far as possible, because exposing a child to radiation again and again is not good. But if it's a really bad X-ray, at times we may need to repeat it. So having seen whether the X-ray is good, now let us proceed to the format of reporting. So how do you report an X-ray? So normally we don't need to know all this, because we are relying on our radiology colleagues to see all the nitty-gritties of an X-ray. But in this case, many a times we have to see it and we have to make a decision and proceed. So it's better to know the order of seeing it, so that we don't miss out on certain points. So we start with the mediastinum. This is the mediastinum. The part between the two lungs is called the mediastinum. You have the heart as well as the trachea, bronchi, major vessels, which are there in the mediastinum. Then we look at the pleural outline. So you can see the pleura, we can trace it down. You can see the costophrenic angle, and you can see the cardiophrenic angle. So this is the pleural outline. You can very clearly see. Third, we look at the hilar shadow. So the hilum is the structure which come out of the mediastinum. So here it basically the vessels and the major vessels and the bronchi, bronchioles. So it is here. So this is the hilum on the left side. This is the hilum on the right side. You compare both sides. Fourth, you look at the trachea and major bronchial lucencies. So you have the trachea coming down, dividing into the main bronchi, and then further dividing into the upper and lower. So that also can be traced to an extent. Fifth, we look at the lung parenchyma. So we're not going to jump and see the lung parenchyma. We use the same format for all X-rays so that we don't miss out on points. In the lung parenchyma, we divide it into upper zone, middle zone, or lower zone. Or in small babies, you can even divide at the level of the hilum into upper zone and lower zone, and then report it. So why do you need all this? Because two people who report it should be reporting it in a similar way. We should not it should not be that a resident finds some other findings and the consultant finds something else. So that should not be there. So all of us should be reporting it in a similar way. Of course, with experience, little changes do come in, but overall the format should be same. And finally, we look at what is beyond the chest wall. We look at the wall, the ribs, whether there is any surgical emphysema, whether there is any effusion, pleural effusion, pneumothorax, all that is looked into. We look at the abdomen. We see fundic gas shadow in many children. So if there is a Ryle's tube, it helps us to locate that as well. And finally, we look at the CP angles. Now the CP angle, what happens is in many children, if it is an erect X-ray, your CP angle is the most dependent part. So this would be the most dependent part of a erect X-ray. So, but in children, I'm just trying to annotate it. Yeah. So this will be the dependent part. So, but in children who are supine, if there is minimum fluid there, if that will actually track up. So once, if in a supine film, never rely on the CP angles to detect pleural effusion for you, it may appear as a haziness in this area also. So that is one problem with this kind of a film. So supine films cannot be relied on. So I don't know how this goes away. So we'll start with the mediastinum. So the mediastinum. Yeah. So the mediastinum, we start with the left and the right borders. The right border constitutes the superior vena cava and the right atrium. So you should note that the right ventricle is not part of the right mediastinal border. So you have the SVC coming down into the right atrium. Why do we need to know this? Because if you have a central line, the tip of the central line is supposed to rest at the junction between the SVC and the right atrium. What happens on the left? You have the aortic knuckle followed by the left pulmonary artery and the veins and the left bronchi and vessels. And then you have the left atrium, then you have the left ventricle. So there are 4 constituents on the left side and 2 on the right side. Now, for a COVID purpose, there is hardly anything which comes significantly in this area, because COVID as a rule, there is not much of lymphadenopathy and not much of hilar lymph nodes like you would expect in, say, tuberculosis. But one thing is, if there is a, say, a pulmonary embolism or a pulmonary thrombus in situ, that can cause strain on the right side. So that can cause an RA enlargement. So that's the only thing I can think of if there is a from which pertains to the mediastinum as such in COVID-19. And of course, the fact that you should look for central line tips. So that is the mediastinum borders for you. Now we come to the second part. So then again in the mediastinum, two more interesting things that you can look at. If it is a PA film, which is good for heart reporting, you can always calculate what is called the cardiothoracic ratio. So you divide the heart size divided by the thoracic diameter. It is usually less than 50%. How do you calculate the heart size? This is A and B, the maximum diameter on the left side and the right side. So this is right and this is left, sorry. This is left and this is right. So A plus B divided by the transthoracic diameter, that can be seen. And if it is more than 0.55, it is called as cardiomegaly. But now that we will look at only at in PA films which are erect and which are inspiratory. So many a times in COVID-19, we don't get that scenario. So in which case we should not be using it for cardiac shadows. Third, if you have something, say suppose there is some mass which has come up here. So if there is a mass here, then we need to see where is it coming from. So if there is a mass which I say, if there is a lymph nodal mass which has come up here, ideally what we usually do after this is we take a CT if we have a doubt as to what is it. Is it just lymph node? Is it a pneumonia on the medial aspect, or is it a lymphoma like mass, or if there is any other mass like teratoma, etc. So how do you differentiate it? It's usually based on a CT. But here in this case, since we don't want to take CTs, it is best to actually take a lateral X-ray. So when you take a lateral X-ray, you can actually differentiate it very easily based on the location on the mediastinum. So lateral X-ray, if you draw a line at the sternal angle, anything above that is the superior mediastinum, anything below that is the inferior. Now, inferior mediastinum is divided into three parts. You have the anterior mediastinum, the middle mediastinum, and the posterior mediastinum. Superior and anterior mediastinum has the same structures. So you have thyroid there, you have thymus there, you have teratomas that can come up there, congenital malformations like and teratomas also, benign as well as malignant. And fourth, you can also have patients who come with some kind of lymph node, terrible lymphomas also, which can T-cell lymphomas can come in that area. So this is the superior and anterior. So if that lymph node, if that mass which I showed in this projection, so if there is a mass here, if you take a lateral X-ray, if it is in the superior or the anterior part, you know it is usually one of these four differentials. If it is in the middle also, it can be usually lymph nodes, and posterior ones, it can be completely different etiology as well. So very simple lateral X-ray can help us localize mediastinal pathology. We may not require it in COVID-19 scenario, but many times you have something centrally, because COVID, everything is to the periphery of the lungs. But if there is something coming only in the central part, we may be forced to look into this. And in COVID scenario, we don't want a CT done because you have to transfer a child. And if the child is sick, that makes it all the more difficult to transfer. So that part is difficult. So now let's see some of the mediastinal outlines. This is a near normal one. So you can see this is the right atrium and this is the SVC, which is coming up here. And then here on the right side, you can see that there is an X-ray and there is some kind of prominence which is seen on this side. So what is the prominence due to? So normally, if we are not tuned to reporting pediatric X-ray, we may think that there is a mass, or we may even think that there is some kind of a collapse of the lung. But see, it is a small baby's X-ray. So when you look at that, that itself should give us the clue that this is nothing but a thymus. And for some reason, thymic masses usually appear on the right side. So right side of the mediastinum. So that is one. And another X-ray is this one. This is much more classical than the other earlier one. And this has the classical, what is called the sail sign of the thymus. And this sail sign of the thymus clearly, it looks like the sail of a boat. And this is again on the right mediastinum. So then again, it is very, very clear here. But if it is somebody who is not tuned to reporting X-rays, then it can actually come up as, this can actually be reported as a right-sided consolidation. So that should not be there. Now, the third part of it. So having finished the mediastinum, now the second part of it is the hilum. So you have the hilar structures here. This is the right hilum and this is the left hilum. And usually hilum is right is little lower when compared to the left. The constituents of the hilum are basically the vessels, and some kind of bronchi, second, third generation bronchioles can come up here. So if there is some bronchial inflammation, which is part of many patients who have viral pneumonias, there can be prominence of the right side of there can be prominence of both hilum, especially on the right side. So this is usually reported by radiologists as pneumonitis or perihilar prominence. So perihilar it gets reported as perihilar thickening, etc. Can be, it's a streakiness, haziness. This kind of terminologies are used, and it can be reported like that. So that we just know that it is just prominence of the hilar contents, that is because of some kind of inflammation or increased vessel flow. The third part of it is the tracheobronchial outline. So you can see the trachea dividing into two, the bronchi. We will see the markings of the endotracheal tube later on. And so that is basically what you need it for. But sometimes, even in viral infections, you can have tracheal lumen intimal thickening, which causes the narrowing of the tracheal lumen. So that is important, especially in children who present to you with stridor. So especially if there is upper airway obstruction, the obstruction can be from outside, that if there is a mass or a lymph node, etc., or if there is a massive pneumothorax, it can push the trachea to one side, it can cause narrowing then as well. So that is one possibility. Another is there is intimal thickening. So because of edema, because of say laryngotracheal bronchitis, etc., that can also produce narrowing inside, and that can result in this kind of picture. And beyond the chest wall, we already discussed. So now coming to the main part of the talk, which is basically looking at mainly looking at the X-ray, the radiological abnormalities, what you want to see. Now, whenever you see radiological abnormality, again, then there is a format of reporting. You need to first of all rule out rotation. We already discussed that. We need to see we need to know how to describe an airspace abnormality, whether it is a lobar pneumonia or whether it is a bronchopneumonia, whether it is diffuse, in which case, what is the terminology that you will use, patchy, streaky, linear bands, what do you want to use? We should see whether it is predominantly central or predominantly peripheral. So in some X-rays, if I bring back an X-ray film, so yeah. So here, if you can see the X-ray, so there is a central part as well as in a peripheral part. So whatever is in this line, so the line that I'm drawing, so here, whatever is in this part and this part, we'll call it is the this part. Mainly this part would be the central part, whereas this area, this part and this part would come to the peripheral part. So most of COVID infection, the disease starts in the subpleural area or the peripheral part, and it goes inside. Predominant involvement only of the central part, it is not COVID-19 infection. So that we must be aware of. So most of COVID, many viral infections have the same pattern, that it originates in the periphery, and then disease, as it progresses, you can see come inside. But only having disease in the central part, it is little unusual for COVID-19 pneumonia per se. So that you need to look at what is central and what is peripheral, so that we have an idea as to whether it is very typical of COVID or it is not typical. And fourth, you need to know the low distribution of the zone. Again, this is all for ease of reporting it or the uniformity of reporting it. So if you have say if you have like this, if you draw a line at the hilum, anything above is the upper zone and anything below is the lower zone. In adult X-rays, it is called upper, middle, and lower. So it is the first two ribs. Above the first two ribs is the upper zone, and between the second, this is the anterior border of the ribs. So you have the second and the fourth. Between the second and the fourth, this area is called the middle zone, and below that it's called the lower zone. So this is upper, middle, and lower in an adult X-ray. In pediatric X-rays, since this area itself is so small, they have put a line at the hilum and called anything above that upper and anything below that lower. So we could follow any of these things as long as we use the same in our unit, and there is a uniformity of reporting. So this is the format. You look at the whether it is lobar or bronchopneumonia. If it is bronchopneumonia, what kind of terminology do you want to use? We look at whether it is central or peripheral. And finally, we look at which is the zone that is involved. And so this has to be adhered to when we start describing X-rays. So one of the earliest X-ray related papers came into 2020 from Spain, which looked at pediatric COVID-19 chest X-rays and reported the findings that they saw. And this was at a time where not many patients were being admitted for COVID. As in pediatric as such, they were seeing more milder cases. So here in this group, they had around 50% patients with comorbidities, and probably that is why they were admitted. So they described two important findings. What are the two important findings? One is called GGO, ground glass opacities. I'm sure all of you would have heard this terminology by now, because many of our friends, relatives, etc., patients were admitted during the second wave, and most CT and X-ray reportings would carry this terminology called GGO. So what is a GGO? GGO is an area of haziness. It is something, is it on the milder spectrum of a consolidation. So here in this X-ray, you can see A, B, C, and D. So, and this is how it progresses. So here, when we look at X-ray in A, you can see this area which I'm marking out, this is a GGO. So what is it? It's an area of haziness. Does it have a clear margin? No. Can you see the lung markings through this area of GGO? Yes, we can see the lung markings. And is there any airway which is going through it? There are maybe airways, but we can't really make out here. So this is how you describe a GGO. A GGO is an area of haziness, which is not limited by a lung margin as such. There is no margin. As you see, when we progress from A to C, now by C, it is a full-blown consolidation. You can see the margins of that
There is a network issue in her side. Please wait. She is joining again.
There is some problem of connectivity. Madam is connecting again. Please stay. Some connectivity issue is there. Madam is connecting. Please wait.
I'm really sorry for the break. Can you hear me well?
Yes, madam. You are audible and slides are visible.
Sorry. So by the time the power goes and the
No problem. Okay.
backup comes, no, the Wi-Fi signal goes off. I'm really sorry about that. So we were describing a GGO. So GGO is ground glass opacity, which is an area which is mild haziness, which does not have a clear-cut margin, and it has lung markings are very, very clear. If you can see, you can still see lung markings going through it. And it, unlike a consolidation, in a consolidation, when the entire airspace is consolidated, you are able to, if there is air inside an airway, See here, you can see what is called an air bronchogram, which is coming through it. Entire area is consolidated and there are very clear markings for a consolidation. Whereas here there is no, that margin is not very clear. So that has to be understood. One. Second, where are these seen? These are usually seen peripherally. These are usually seen in originating in the periphery. It could be coming to the central, it could be multifocal as well. So these are multifocal, subpleural or peripheral, and bilateral GGOs that are coming up. So that is the thing about ground glass opacity. So initially they were used for CT scans per se. And even, I think we see GGOs have been used earlier also. So especially in children who have viral pneumonia, bronchopneumonia, etc. If you do a CT, not related to COVID, GGO is a finding that can come up there also. So, but now the COVID has taken over so much that in all viral pneumonias, now not just in CT, you are reporting these findings even in chest X-rays as well. What is the second finding? So this is again another picture which shows the same GGO. So just to put it, GGO looks like a frosted glass. So you can see frosted glass. If somebody is standing behind the frosted glass window, there you can still see the shadow. You can see that somebody, you can make out that somebody is there. Depends on the degree of frosting, but mostly if it's a milder one, you can see that there is a shadow of the person behind, it can be seen. Whereas if it is a completely opaque glass, then you cannot see. So that is the difference between a ground glass opacity and a consolidation. And basically ground glass, it starts off as a GGO and it progresses to consolidation and then it resolves again. So this is how the pneumonia progresses. The second finding they described was called peribronchial cuffing. So this I already told you that there are these hilar vessels and hilar bronchi bronchioles which are there. So what happens if we are seeing the X-ray? If you have an X-ray like this and the bronchus is like this, it is coming like this, you can see it as prominence here. So this prominence is coming up here, which you are seeing. So, but suppose, so this is the prominence that you are seeing here. But suppose you are seeing the end-on view. So if you are seeing the end-on view, then the end-on view, that bronchial wall will be thickened because there is some kind of edema of the bronchial wall because of viral infection. So this kind of thickening comes up as what is called a peribronchial cuffing. So I've removed the color so that you can see that there is airway inside, there is air inside the bronchus, and the wall is thickened because of the edema. So this is called peribronchial cuffing, and this peribronchial cuffing is not specific at all for COVID, but it is highly sensitive. More than 80% patients will have this kind of features. And it can be seen in other also, like if you have an H1N1 influenza, all those patients can also have, it's not related to only COVID, but it is not specific. So that is highly sensitive, but it is not specific. So based on this, they found they had a consensus guideline which came up as to how we should be reporting these X-rays, and this reporting format was later described in an international consensus forum. So I'm just trying to close this. So based on this, consensus guidelines came up, and this guideline called it typical, indeterminate, atypical, and negative findings for COVID. And the typical findings of COVID-19 pneumonia in children were: one, patients who had bilateral GGOs, which were multifocal and which were peripheral in origin. So bilateral, peripheral, multifocal GGOs were called typical findings. So if you, so much so that if you find that in any patient, you should be thinking that this is COVID and you should evaluate for COVID. It is that specific. Two, indeterminate, when patients have findings which may be there in COVID, which may not be there in COVID. So these included that peribronchial thickening that we described. So peribronchial thickening, then patients who had unilateral GGOs, that is also not very typical. Patients who had GGOs without a specific distribution, like there were central and peripheral GGOs, so that is again indeterminate finding. Third is atypical findings. Very, very important to know what atypical findings were. Why do you want to know it? Because if you have these kind of atypical features, you should be ruling out other infections or other diseases. So lymphadenopathy is a very important atypical finding. Lymphadenopathy, pleural effusion, patients who have lobar consolidation, patients who have central consolidations, all these are highly atypical. And even in the series of patients that we have followed here, as well, there have been patients who in whom tuberculosis was diagnosed along with COVID-19, or lymphoma was diagnosed along with the COVID-19. So if there is significant lymphadenopathy, it cannot be COVID-19, it has to be something else. Or even if there is COVID positive status, you need to be looking for an underlying cause for the lymphadenopathy, and it should not assume that it is because of COVID-19. So these are the atypical features. Again, I'm listing it out once more. Lobar consolidation, central GGOs, patients with single round consolidation, pleural effusion, and lymphadenopathy. And if you don't have any findings, that is reported as negative. So we'll see some typical and atypical X-rays. This is a typical one. So here you can see the GGO. You can see that it is more prominent in the subpleural area, and then it's thinning out as it goes to the central part. So this is a bilateral or a multifocal GGO, which is subpleural in origin. Very clear. It is a GGO because it is a mild haziness. There is no margin as such. You can see the lung markings clearly. And finally, you can't see an air bronchogram. So that is how you differentiate. What happens here? Here it is a right upper lobe. So this image is that of a right upper lobe consolidation. So that per se should not COVID-19. You should be looking for something else. So this is atypical. Here you can have in this right lower one, you can have patients who have bilateral findings. There are some peripheral findings, central finding. So this would be indeterminate. It will not be very specific for COVID per se, but then COVID should be ruled out in this one. What about the other ones? What is this? This is a central Rhine-Brown pneumonia. So this again should be per se this without any other peripheral findings. You should be ruling out another cause, probably a bacterial pneumonia. If the child is running fever, it may be a good time to add on antibacterials as well. And here you can have bilateral central, but then there is some small findings in the periphery also. This is indeterminate. It could be COVID, it may not be COVID as well. So now these are the COVID pneumonia, some more X-rays. This is again interstitial pattern, bilateral interstitial pattern. Interstitial means just there is fluid in the interstitia that take this kind of prominence. The hilar prominence is very marked in these kind of patients. Here again, bilateral interstitial pattern, more on one side. And here you have right lower pericardial interstitial pattern. You can even see the cuffing in couple of films. So this is again findings which are sensitive. These could be COVID, but it may not be COVID as well. So these are indeterminate findings. And this is again a peripheral focal consolidation, but this is a peripheral onset. So this would be indeterminate. And perihilar streaking, I already told, this is highly sensitive, but it is not specific for COVID-19. So can X-rays predict severity? Radiologists would say yes. As clinicians, I think we should not be basing X-rays for the severity. Severity would be what we have already discussed in today's session, that we will be looking at the work of breathing, we'll be looking at the respiratory rate as well as the saturation to decide the severity and treating based on that. So these are two X-rays. These are all X-rays from my patient's department. So these are children with leukemia who were admitted. So this was the first child with leukemia, 2020 admissions. You can see the saturation is to know it is a severe COVID-19 pneumonia. X-ray is also suggestive. There are bilateral lesions, bilateral, multifocal, peripheral onset lesions. These are probably past the GGO phase. Now it is more like a consolidation. So this is one child, and this is another. Again, there are GGOs as well as consolidated areas. Bilateral, very typically you can see that it is originating in the subpleural area. And this is again a child who was significantly hypoxic. Both of them required HFNC and they improved. And next is Dr. Thank you. So these are X-rays from this year, 2020, and the second wave of COVID. And here you can see that there are two children with X-rays which were almost as bad as the earlier X-rays. This is a child with severe anemia, and the COVID. This is the picture. Yourself, Sanjeev. The host mute. Mamta. The group, if there is
Dr.
somebody.
Sanjeev, please mute.
Thank you. So here you can see that there are patients who are, again, X-ray is as bad, but if you can see the saturation is above 95% in room air. Both of them did not even require oxygen. So X-ray have the point being that X-ray does not predict severity. And two, if your patient is otherwise improving, no need to repeat an X-ray again and again. So these are children who recovered without much of COVID specific care at all. So although radiologists will tell you that there are ways of assessing the severity, but I think it should be more used for research purposes than for usual clinical care. And finally, we look at the tubes and lines. You have endotracheal tube, which is coming here. You have a Riles tube, which is going down. So where is an endotracheal tube supposed to rest? It is supposed to be around 4 to 6 centimeters above the carina. Carina is the area where the trachea divides into the two bronchi. So this is marked out. You can see the earlier X-ray. So we can still make out the air shadow of the trachea dividing into the carina. And once we mark it out, see it is almost 4 centimeters above. But in a newborn, it will not be 4 centimeters. It may be 1 to 2 centimeters also, which is also perfectly fine. You can in this X-ray see a Riles tube also coming down. Riles tube, you really don't need an X-ray to locate it as such. But if you're taking an X-ray for some purpose, no harm in locating the Riles tube as well. Third is the central line. We already discussed that it should rest at the junction of the SVC and the RA, and this is where the position is. This is another X-ray. Let's see if we can trace it. So this is a PIC line. It's a peripherally inserted central line. It has been inserted in the left side. From the cubital area, you can track it up. I'm just marking it out. So it's coming here, 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 and finally it is resting here. So the tip has a small silicon marking. So because of which we can see clearly that it is at the junction between the SVC and the RA. So that is how you locate the tip. So wherever you put the line, whether it is a PIC line or a IJV or a subclavian line, all of it should come and rest. The tip should be here. So that is central line tip. Riles tube tip, again, another one. This is a very badly rotated film. So this X-ray should not be used for rotating, X-ray should not be used for marking or anything about the lungs as such, but of course you can use it for the Riles tube tip. So this is how a film is. And finally, if you have an ICD, so here you can see the ICD, an intercostal drain is there, and that is probably for the pneumothorax. And if there is an ICD tube, usually there will be some air link into the subcutaneous tissue. You can see the surgical emphysema as well. Another use of an X-ray in this picture, in this scenario, is for ventilated patients. So patients who are ventilated may have complications like a VAP, by ventilator-associated pneumonia, or patients who have pneumonia or barotrauma, like you have been doing CPR or you've been bagging the patient. So there will be some barotrauma and pneumothorax which can come up. So all these can be looked up in the X-ray. You can find all these findings. If you have a patient who is not improving or suddenly deteriorating, you're thinking of a pneumothorax, always look for an X-ray, ask for an X-ray. Second complication you can see in COVID scenario is a patient, non-ventilated patient who develops a secondary bacterial pneumonia or a secondary fungal pneumonia. So all these can be again made out. And third complication is a pulmonary artery thrombosis, a child who's not improving, saturation not picking up despite all the treatment that you've given, D-dimers are going up. Then you think there is a thrombus in situ, in which case X-ray may be taken, but X-ray won't help us much. You need to be doing a CT chest or a CT angio for the same. And that's probably the only indication for CT in this scenario. So these are fungal infections. Secondary fungal infections have been reported in COVID-19 scenario. This is another patient who had fungal pneumonia. So you can see there is a GGO which is starting here. And after a few days, it has progressed and now it is a full-blown consolidation. And what interestingly, you can see the cystic spaces. I'm going to mark it out again so that it can be clearly seen. So here it is, here you can see the mark. This is fungal cavities which are coming up in patients who have fungal infection. So this also tells you that that this is there are some cavities which are coming up. It's likely fungal. So the same PIC child the same picture of the same child. So you have seen necrotic areas in the nose. So this one was aspergillus, but many times in COVID, mucormycosis has been reported. The treatment is same, amphotericin only. And this is a picture after improvement. So this is the second part. Second, in ventilator patients, you look for VAP. We look for ventilator patients who are going in for pneumothorax, pleural effusion, and ventilator-associated pneumonia. So this is pneumothorax. You can see the lung margin here, very clear. A patient who has, see the collapsed lung margin, which is coming up here. And here you have free air outside it. So you can't see any lung margins here, just free black air. So that means you know that there is a leak in from the pleura. So this is the lung margin that you can make out, which is collapsed. Here on the right side, you can actually see that there are both sides of the lung seem to be perfect. There is no pneumothorax as such, but if you can track this, you can see some air here. You can see some air. I'll just remove it so you can see clearly. So you can see the air in the pneumomediastinum. And on what else can we make out in this patient? There is some kind of air in the spaces as well. You can see air in this area, the area where I'm marking out, which is in the neck area as well as in the axillae. You can see air which has come up. This is all surgical emphysema because of the pneumomediastinum, which is tracking up and going into the subcutaneous space. So this is the fourth. And when do we do X-rays? We generally ask for X-rays similar to that of any other child. So you usually take X-rays in patients who have moderate to severe respiratory distress at admission. 2, you will ask for X-ray if there is any worsening. If a child is improving, you don't need to repeat an X-ray. And CT is probably indicated only for pulmonary thromboembolism. And sometimes if you have like really bad lungs, if you have suspected fungal, etc., you can do a CT as well. But ideally, most of the decisions can be made on an X-ray itself. Only thromboembolism is the scenario where you need to do an X-ray, CT, either a CT chest or an angio. So in conclusion, when you order an X-ray for any moderate or severe illnesses and when you have complications that are suspected, you look for lung parenchymal findings, complications like pneumothorax, pleural effusion. You can look for surgical emphysema. You can look for pneumonias, fungal pneumonias, etc. You look for endotracheal tube position. You look for central line position, ICD tube position, as well as the Ryle's tube position. And do you need to repeat a chest X-ray? It is not required unless there are any complications that are suspected. So these were the objectives for today. To pick up a radiological abnormality related to COVID, we did see what is typical, atypical. We looked at even judicious use of X-rays in this scenario. We identified the tubes and lines, and we have talked about complications related to mechanical ventilation. I thank all the contributors for these slides, and I'll be happy to take any questions.
Thank you, Neeta madam, for excellent talk. There are few questions. One person is asking a repeat how to check rotation.
Should I project that? So rotation is basically looked at from the side clavicles itself. So I'll bring up X-ray film first, and then I'll tell. So here you can see the clavicles on both sides. So the clavicle should be symmetrical to each other. So that's how you know the rotation. And another way is looking at the trachea. If the clavicles are symmetrical, the trachea should be usually central or slightly to the right. But if one clavicle is on one side and the other one is looking the other way around, so you have, so this X-ray you can see on the left side, this clavicle is like this. There is slight rotation. That is why this is looking like this. There was one more X-ray on that Ryle's tube one, which was really bad. See, this is a completely struggling baby. So that's where everything is looking rotated. Although we can't see the clavicles here, you know that this is rotated. Even this X-ray is rotated. The clavicles are not looking symmetrical at all. So that is how you know whether there is rotation or not.
Another question is, if the X-ray comes to be indeterminate, then what should be done?
Nothing. If it is indeterminate, you can treat as COVID. And if it is atypical, look for other causes as well. So even if a child is, say, COVID positive, admitted in your facility, your X-ray comes, it shows either miliary findings, miliary shadows, it shows pleural effusion, it shows massive lymph nodes. Of course, you will be starting treatment for the COVID part, but the reason for that X-ray finding is not COVID. You need to look for other things like tuberculosis or bacterial pneumonia.
Okay, excellent, madam.
Thank you, sir. Thank you to all of you. Thank you to DGME for this opportunity.
Chandrakanta, madam.
Yes, I think we can conclude now. So
Yes, ma'am.
I thank all the speakers for this excellent job done. And thank you, Dr. Chaudhary, for sparing your time. And I thank all the participants for interactive session. So please join us again tomorrow at 12. So thank you all.
Thank you, madam. Thank you all.
Thank you all. And just want to share those who have submitted successfully their pre-test, only those participants will be receiving links for the rest of the days, basically day 2, 3, and 4. Thank you.
Okay.